नमोस्तुते दीपज्योतिर्नमोस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीप
Ongoing regional tensions. Iran
हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु
Yeah, this is Bharat-Pradhan. What is this? Mantri? Yes. ಇದು ಆಡಿಯೋ ಇದರಿಂದ ಕೊಡ್ತೀರಾ ನಿಮ್ಮ ಇದರಿಂದ ನಾನು ಆಡಿಯೋ ಕ್ಯಾಪ್ಚರ್ ಕಾರ್ಡ್ ಎಲ್ಲಿದೆ?
You need printer or no? Printer.
No, this and this will not get the. No, it will have. You need to install drivers, other driver. So better is. Huh? So he can facilitate.
Okay.
He needs print itself. So
Yes.
no. Actually, driver has to be installed in any laptop. This has got driver, so it picked it up. So you have to. Brother driver you need. Brother is the name of the printer.
Send it to my ID. millions I not for charge. So we is the outside.
Once edited, I edited random editing Ayushman. One way to go ahead here. Because I do.
told, it was only trained on what is being trained on, limited set of data. After few days of this frustration, what I did is I just left it. I said, yaar, koi baat nahi, ab kuch nahi kar sakte. So the moral of the story is there was no human in the loop. Because there is no human in the loop, the problem just builds up and there is nobody to see. I don't know whether somebody is seeing that data that is being fed to the chatbot, the customer interaction. So there was no human in the loop, and out of frustration I left it, and there will be so many other people who would have had a similar experience, and you have no way to go. So what we have done is in the auto adjudication that we have implemented, or we plan to scale it, these were our learnings, and we thought there has to be a human in the loop, because without human in the loop, it is hospitals which will get harassed, or which they will not even know where to go, how to resolve their problem, because it's AI, it's the data. They don't differentiate, but they don't understand also. So there is lack of empathy in the data or AI model. So these were the few learnings that we had when we started with designing the hackathon. Now I'll formally read out my speech, which I have prepared. I want to begin with a number. I want to begin not with a number or with a policy, but with a silent movement in a hospital corridor, somewhere in a district hospital in Jharkhand, or a small facility in Odisha. A woman is waiting. She has been told she needs surgery. Her family is outside anxious. The doctors are ready. PMJ has promised to cover her care. And yet she waits. Not because the medicine isn't there, but because the pre-auth is still being processed. And this we have seen in PMJ. That wait measured in hours but felt in heartbeats is the problem this room is assembled to solve. Though this problem is for auto-adjudication, but the similar solutions will be deployed in the pre-auth stage also. PMJ has over the years become one of the largest health assurance program. I think all of us know that. It is not because what the government announced, because there are so many schemes which are announced, but obviously during implementation, how impactful that scheme is, that varies. And it has quietly delivered at the last mile. Over 8 crore hospitalization, families who did not have to sell their land, borrow from moneylenders, or simply turn away from care because it was out of reach. So PMJ has transformed the healthcare landscape of India. However, as scale grew, delays and errors in claim began to affect trust, access with hospitals, at times hesitant to treat beneficiary due to pending payment, which is logical. Auto-adjudication addresses these challenges by ensuring faster, accurate, timely claim settlement, giving hospital confidence to provide care, and ensuring beneficiaries are not denied treatment when they need it most. In doing so, it reinforces the core promise of PMJ: timely, cashless, dignified healthcare for every eligible family. I admit, standing before a room full of data scientists, engineers, and medical professionals, that my own background doesn't involve much coding or medical knowledge. To me, the world of automated workflows and machine learning often felt like a language I hadn't yet mastered. Neither I'm a doctor nor I'm a IT person. Organizing a hackathon of this scale, focused on such a complex intersection of healthcare and AI, at times I felt that I don't know where it is heading. There were moments when we were when we were facing serious challenges with our data platform. Then we were facing challenges with our deadlines. Initially, we faced a lot of problem with our problem statement, because it was very difficult to firm up that these are the problem statements on which we want to go ahead and have the solution, and it will deliver what we want it to deliver. So there were challenges, and I thank my team for having patience and having faith. But it is the team which is sitting here silently who has done all the hard work. And but perhaps being a non-technical voice in this process was its own kind of strength. It allowed me to keep asking the simplest and the most difficult question: how does this keep the person at the end of the line? We pushed for solutions that were not just clever, but were just. We didn't wanted the coolest tech. We wanted the most compassionate tech. But that, I think, is also the point. Government does not need to have all the answers because we cannot have all the answers all the time. It should not pretend to. What it can do is ask the right question, create the space for innovation, and then, crucially, be willing to listen. And out of our exercise of doing that, this hackathon, what we got is the ideas and the approaches that understood not just the data, but the human being behind the data. As I said initially, that data has its own biases. So we have tried our best to ensure that that problem is taken care of, or if not taken care of, at least we are aware that this may arise, so we have to take care of that. What makes this especially powerful is who delivered them. Students, AI researchers, professors, startup, all bringing fresh thinking and deep empathy to real system challenges. That collective energy and purpose is what I'm most proud of today. To the participants, you engaged with a problem that is unglamorous by the standards of tech world. There are no viral applications here, no consumer applause. What there is a consequences, a beneficiary who wait less, a hospital that can move faster because the system trusted it sooner, a family that goes home knowing the promise was kept. You showed up for that, and that matters more than I can say. What we want now PMJ to do is that at least the beneficiary and the hospital does not have to bother about the claims, and beneficiary should not bother about the treatment. What they need to now focus is on getting better. Thank you.
Thank you, ma'am, for setting the strategic context so clearly and precisely framing the issues which we need to ponder over next 2 days. Ladies and gentlemen, we are gathered today on the campus of one of the most distinguished institutions of our nation, Indian Institute of Science, established in 1909, and we are fortunate to have Director, Indian Institute of Science, Professor Govindan Rangarajan, with us. Professor Rangarajan is a distinguished academician and leader, widely respected for his contributions to research, innovation, excellence in higher education. And under his leadership, Indian Institute of Science continues to lead India's most ambitious work at frontier of science and technology, including healthcare, AI. So now I invite Professor Govindan Rangarajan, Director, Indian Institute of Science, to kindly address this gathering.
Good morning, Secretary Mighty. Oh, this changes. So Secretary Mighty, CEO NHA, and Joint Secretary NHA, and all other dignitaries who are gathered here, and of course all the participants. On behalf of IAC, let me warmly welcome all of you to this campus. I hope you have a very productive discussion. And I think the topic that we are addressing is also very critical given the state of AI and its impact on healthcare and all other areas. So we come to, we sort of hear about AI's impact on so many areas. Just recently, there was a study in Science which said that now AI does better than doctors in ER situations, where they've shown that in emergency rooms, AI does better. Another study said pancreatic cancer can be detected much earlier by AI compared to doctors. So these are, but at the research frontiers, and of course for all these advances to really percolate down to the common man, it may take some time. But what this hackathon addresses are more immediate issues, what can benefit day-to-day the common man when they are looking at insurance claim adjudication, because the topics which are being addressed, like, document classification, forgery detection, etc. These are the things which can hold up the processing of claims, and so having good solutions can really benefit the common man. So I think that I find very interesting, that whatever solutions are being developed are being done for the common man. But of course, whatever solutions developed now, we have to make sure that these are very secure, because we are dealing with very important and very personal data. We have all, heard about Mythos, the Anthropic's, cyber security solution. So we need to ensure that, that we are secure from such things, and also now post-quantum cryptography may also be required to secure these databases, given that Google has now advanced the date to 2029 when all systems have to be secured against such attacks. So there are a lot of challenges also, and already the bias and other things, user issues have been pointed out, but these are also important given that we'll be dealing with highly personal data of the common people. So I think you are here on a very important mission, so where you are addressing very important issues, and I wish you all a very productive hackathon, and I hope we come up with very good solutions. Thank you all.
So thank you so much for your insightful remarks and giving us an opportunity to host this grand finale event of Auto-Adjudication Hackathon at the campus of Indian Institute of Science. Ladies and gentlemen, we'll now hear from the Chief Executive Officer of National Health Authority, the institution that anchors this Auto-Adjudication Hackathon. Dr. Sunil Barnwal is dynamically leading the National Health Authority with its twin missions, Ayushman Bharat, Mantri Jan Arogya Yojna, and Ayushman Bharat Digital Mission. And under his leadership, we continue to grow and roll out digital reforms, both in claim adjudication as well as in electronic health records generation and its use for the larger good. Now, I invite Dr. Sunil Barnwal, CEO, National Health Authority, to kindly deliver his address.
Good morning, everyone. Dr. S. Krishnan, chief guest of the occasion, and Secretary Meti. We have Dr. Govindarajan, Director of IISc Bangalore, Joint Secretary Ms. Jyoti Yadav. We have our Joint Secretary Kiran and Sanjay Mehersi too present here. I see the presence of Ms. Uma Nambiar, who is heading the medical hospital in IISc. We see Mr. Phanindra, who has been helping us through the Center of Excellence for AI in Healthcare. We see Raghu from Art Park. So there is a good presence of dignitaries today at this occasion of this final showcasing of Auto-Adjudication Hackathon. We have the presence of hospitals, insurers, ISAs, TPAs, a state health authority officers. As a good number of participants, I can see the benefits of it while we are organizing this two-day event. Let me just give you a small background. When I joined NHA, it was something I found, huge opportunity lying ahead for all of us to not just deliver healthcare through the government assurance health program, which we call Ayushman Bharat Jan Arogya Yojna, but also to make whole healthcare delivery system much more efficient and effective through technology. And when we talk of technology, we all understand it doesn't lie with one organization or few individuals. It lies across the society with different organizations, different individuals, different systems. And this is what we want to leverage by organizing such hackathon. We did the first hackathon on AI in healthcare while we were developing open benchmarking data platform for testing health AI with IIT Kanpur. That same platform was launched during the India AI Impact Summit, and India has become the first country in the global south to have such platform which can give a score or validation to health AI against Indian data sets, which is extremely important, and Jyoti has rightly flagged that issue with use of AI in healthcare. This is something which has been made as a digital public good for any deployment of AI at scale in India. And so this becomes extremely important. Subsequently, with IIT Hyderabad, we did another hackathon in association with IRDAI on National Health Claim Exchange, which has also gave us a lot of good solutions, which we are going to take some of them at a scale, and it will actually streamline the claim processing with the insurance companies and the healthcare providers. In series, and the idea came from the previous two. When government is the largest insurer for a health program, I think it's a high time that we do something which makes it much more efficient while processing the claims. And this is how we decided a month back to open a hackathon on auto-adjudication with 3 problem statements, and you will see today the winners of those who provided solutions, and they will make the presentations today. We can see some of them will certainly will get applied in claim adjudication. This idea also came from some of the in-house exercise we did in National Health Authority with our own in-house team, and we have the directors and the whole team present here, who could design the auto-adjudication with the existing resource for 2 packages. One was dialysis, and another was for cataract. And these were the packages where the value was much less, but the volume was too large. And you see, the time and energy we spend in claim adjudication for each one was more or less same, irrespective of the value. So while we optimize our time and energy to do the claim settlement, we realize we will take these 2 cases, and I must tell you, the average claim processing time has come down from about 20 days to 4 hours. So this is the power of technology which we saw, and subsequently we decided to hold a hackathon which makes package agnostic solution for claim adjudication for almost all packages, and this is what we will see in the winning solutions which they will present today. So when we say claim adjudication, this is something probably patients are not aware of. And sometimes we see this is advantage because the patient, when they go to hospital, they need not worry about the finances, they need not worry about the claim adjudication. But every claim adjudication has consequences on healthcare delivery subsequently. So unless we do a efficient claim adjudication, I think the hospitals, the healthcare providers may not be able to provide the efficient health care to the patient. So while the patient in their interaction with the hospital may not see that, but they can feel the consequences subsequently. So the claim adjudication becomes a very important aspect in health insurance or assurance program. And this is what we are finding very important, because not only it makes it much more efficient, it also allows hospital to trust the authorities that their claim will be processed with transparency, with efficiency, and with lot of objectivity. So this we have realized, and we find that this will make lot of impact when we run these healthcare programs at a scale. When we think of Ayushman Bharat PMJAY scheme, the volume is too high. In fact, almost every day, around 80,000 patients get treated under Ayushman Bharat scheme. Almost every day, 40,000 claims are processed in the system, and it varies from a few days to few months in the processing of these claims. Almost every day we are treating patients of the value to the extent of 120 crores. Every year we spend about 45,000 crore in treating more than 2 crore patients. So if these are the volumes, I think the efficiency makes a lot of sense when we reduce even with few days or few hours, because it has a huge impact on large number of healthcare providers, and which is about 35,000 in numbers. So this brings a lot of efficiency, transparency, trust in claim management, not just the operational goals of doing the claim settlement. So I think this hackathon has become really important when we are talking to take advantage of technology to make healthcare programs much more efficient. Now, National Health Authority runs two major flagship schemes of Government of India. We are all aware of this Ayushman Bharat-Pradhan Mantri Jan Arogya Yojna for providing health cover of 5 lakh rupees to bottom 40% of the population of this country. But there is another very important scheme which we run. It is called Ayushman Bharat Digital Mission. We all know this scheme is not just limited to the hospitals or the stakeholders working for PMJ. This is for whole healthcare ecosystem. Everyone involved in healthcare delivery in this country, whether it is a hospital, pharmacies, diagnostic labs, professionals like doctor, nurses, healthcare, allied health professionals, these all are affected. And their whole identity and sharing of records makes the system highly connected, integrated, and finally extremely intelligent. So while we are using technology to generate a lot of data, I think with AI coming in, it gives huge opportunity to derive a lot of intelligence out of it. As Professor Govind Rajan mentioned, that how AI is actually detecting diseases much earlier, doctors can do that. How AI is predicting something which we could not have done earlier. And this is all possible because there is a data which is feeding AI models to do all these kind of work. So if we have the data, and I must tell you we have about 120 million patient treatment data, and these data are extremely diverse from one corner of the country to another corner. I think this is the most representative health data of the country. So now with these data, actually the biggest challenge lies is how to use that data for research, for development of new drugs, for detection of disease much earlier, to understand the disease surveillance, to do the disease mapping of the country. This all is possible, but then we need to have solutions which actually make these data usable. And these data cannot be used as it is because it contains personalized information. And therefore, it need to be anonymized, it need to be made available in secured environment so that those who actually want to use it, like researchers, the pharma companies, they can use it without actually knowing the personalized information in a secured environment. So this is a possibility, and I must thank IISC for helping us do that. With few packages we have started doing that. I must thank Professor Fanindra. Through the Center of Excellence for AI in Healthcare, there has been a lot of progress for using the health data for research purpose, for developing new equations for kidney and other diseases. So this is all happening. This will happen more if we collectively work together. We actually leverage the brilliant minds of the country in identifying and generating solutions to solve real life problems. And here is the occasion. Through these two schemes, we will be able to do that. I must thank Honorable Secretary Meti, who is also CEO of India AI Mission, to help us in actually developing some of the AI models for the healthcare. In fact, it is extremely important that India develops sovereign models, which there is a lot of efforts happening. But for healthcare, maybe there could be purpose specific small language models too, which we feel there is a lot of use, and therefore we are taking advantage of our presence for 2 days here in Bangalore to actually mobilize such companies who are working in these fields. We also want to tell to the all hospitals, healthcare providers, to actually do the processing of whole patient journey in the hospital in an electronic environment. That is how you will generate electronic health records, which are not just available at the hospital, it will also be available to the patient, it can be shared, and finally, it can also go directly to the NHCX for claim adjudication. This will build lot of confidence between the healthcare providers and healthcare payers. These could be payer could be government, it could be insurance companies, but all together the payer and provider, they can jointly work and actually develop a much better solutions for claim adjudication, and finally efficiency in healthcare provision. So with these words, National Health Authority remains committed for making healthcare delivery in country highly efficient, more integrated, and very intelligent. With these words, I wish this 2 days event, which will also have 3 panel discussions and very important panel discussion in which experts will participate. And mostly they are on the claim adjudication, like future of the claim adjudication, fraud, waste and abuse in claims. And such kind of panel discussions will also bring a lot of ideas which we would like to implement in our, our objective of making healthcare efficient. So with these words, once again, I thank everyone who is participating in this 2 days event, and I thank all my team who has worked continuously for last 1 month, right from identification of the problem statement till the evaluation of the solutions which came. I also thank all the jury members who took all the pain to evaluate more than 75 solutions which came for each of the problem statements. And these had not been very easy. It must have been very tough to distinguish the solutions and get the best out of it. So we'll see that happening today. So once again, I thank everyone for participation, and I wish this 2 days event a big success. Thank you very much.
So thank you so much for very clearly laying down the rationale for this event, this hackathon, as well as laying down very clearly the digital transformational roadmap for National Health Authority. Ladies and gentlemen, we now move to the keynote address of today's opening session. And we are honored to have one of the India's most distinguished technology leaders as our chief guest to deliver the keynote address. Sri S. Krishnan, Secretary, Ministry of Electronics and Information Technology, Government of India, is a distinguished IAS officer with extensive experience in governance and public policy. As Secretary MITI, he is leading India's digital transformation, driving the India AI mission, and is steering the country's broader and emerging technology agenda. The India AI mission's partnership with NHA is at the very heart of why we are here today. So now I invite Sri S. Krishnan, Secretary, Ministry of Electronics and Information Technology, Government of India, to kindly deliver the keynote address.
The CEO of the National Health Authority, Shri Sunil Kumar Banwal, the Director of the Indian Institute of Science, Dr. Rangarajan, Srimati Jyoti Yadav, the Joint Secretary in NHA. Ladies and gentlemen, before we go any further, I think I should disabuse you of any illusion that you may harbor that I'm a technology leader. I'm not a technologist. I should make that absolutely clear. I'm a civil servant, and by sheer virtue of having spent enough years in the civil service, end up at a position where you lead a ministry which deals with technology. So in that sense, it's interesting that civil servants get to head what in Government of India is essentially a scientific ministry, but it's a good opportunity to understand the interplay between how policy works and how technology can work, and whatever contributions that can be made in that fashion. Let me at the outset thank the NHA for involving the Ministry of Electronics and Information Technology and the India AI mission with the work that they are doing, and also associating us with this particular event, which is being hosted as part of the activities of the Center for Excellence on AI in Healthcare, which has moved now and is operating out of Indian Institute of Science. I think it reflects the way that three different ministries of the Government of India come together, converge, in order to deliver what would be truly impactful outcomes. Our concern in the India AI mission fundamentally is to make sure that we are able to bring AI to bear in real world situations in a way that would make a significant difference to people's lives, in a way that we can actually make sure that AI makes the kind of delivery of service possible which would make a difference to all of us. I think that is the critical element that we are looking at. Fundamentally, what are the ways in which artificial intelligence as the newest horizontal technology, in a way, I mean, it's wrong to really actually say newest because it's been around for almost 60 years plus, but at least a technology which can finally be applied at scale, ways in which it can actually be adapted to what we need in the country on a day-by-day basis. which is why I think there are various parts and various pillars under the India AI mission which try to bring together and try to make sure that this broader objective is achieved. It's important from two angles. One, that here is a new technology which can actually be used, and two, India is probably one of the best places where you can actually, we have demonstrated that it's a place where technology can be applied at scale and it can make a significant difference. The stories of our digital public infrastructure by now are well known. And truly, AI represents the opportunity of overlaying AI over DPI to make sure that the benefits are sort of delivered on a much wider scale, on a much more significant scale. So that is truly what we are attempting to do. And the India AI mission basically attempts to ensure that we have what we need in terms of infrastructure in this country, whether the first and foremost being compute, adequate access to compute facilities, the next being data sets, and that's critical. And there again, what NHA can do with us is extremely significant. Currently, we have about 10,000 data sets which are there in the AI-CoE. And how do we sort of build this further, and how do we make sure that without compromising privacy and without compromising security, we present this data in a usable format so that it can make a significant difference. And third is models, and models which are specific to India. There was a fair amount of debate on whether we should just use existing open source models or whether we need to devise models which are specific to India. At the outset, Joint Secretary Mrs. Yadav made this point, saying that if you don't have models which are specific to your circumstance, culturally it can generate a number of biases and a number of issues. And therefore, the need to have models which are specific to India's linguistic and cultural context is also very important, and that's something the India AI mission has attempted to do. But all these three things are important for one more thing which falls outside of this, which is fundamentally applications. That's where literally the rubber hits the road in terms of what needs to happen and what needs to be delivered. And that, I think, is truly the significance of today's event. The significance is that we are actually looking at specific applications which are being developed in one of the critical spaces, which is healthcare. Our belief is that AI should really actually deliver value in real sectors of the economy, whether it is agriculture, whether it is manufacturing, whether it is education, whether it is governance, or it is healthcare. I don't think it's anybody's case in India that either whether it is in the governance space or in the healthcare space or in the education space, we are able to deliver services of adequate quality to meet the expectations and aspirations of our citizenry. It can't be anybody's case that we've already reached a satisfactory level here. And we are also well aware that given the constraints of the fisc in terms of having adequate finances available, we are never going to be able to have the number of doctors you need, the number of nurses you need, the number of other professionals you need in any sphere, and specifically in the healthcare sphere. Therefore, any technology or any application of a methodology which would enhance the productivity of key workers in this space is something which needs to be welcomed and which needs to be encouraged in a manner that is that truly makes a difference. And that's, I think, the opportunity here. And within healthcare, there are a number of things that can be done. Already the 3 hackathons and what they are attempting to do and the kind of solutions they are attempting to do are clearly one area which is very relevant in terms of radiological interventions and what they can reveal. There are a number of startups, and that's the other important pillar of the India AI mission, the kind of encouragement we provide to startups to actually work in this space, who are actually looking at ways in which you can look at X-rays and figure out very quickly whether there is any kind of condition which needs attention, usually tuberculosis or something along those lines. Likewise, we have a number of other applications which have been attempted. In AIMS in Delhi, we are now attempting, and there are other startups which we're trying to do it in private medical facilities as well, where the doctor-patient interaction itself is being recorded, and then it makes the doctor much more productive. It makes it much easier in terms of, quickly the whole thing is recorded, and then it is reduced into the notes of the doctor, and the whole thing is available for further activity. Likewise, you could look at various other diagnostic material which is provided in order to identify. Dr. Rangarajan already mentioned the way in which you can identify pancreatic cancer faster. So all of these indicators and ways in which this can be done is clearly something that the healthcare industry can truly benefit from. Likewise, there's the possibility of running ICUs remotely. This is another aspect which has often been raised with us. So each of these are distinct possibilities and ways in which AI can actually be applied in order to improve the quality of service, in order to improve the timeliness of what we do, and in order to make sure that we are able to deliver more services to the people of the country who need this. There are sometimes, we blame our health system quite a bit, but oftentimes we don't realize how significant it is. Anybody who's been overseas and waited to meet a doctor, and you'd have to wait weeks on end before you even get an appointment, or you were in an emergency room and had to wait hours on end lying on a stretcher without getting attention. We need to recognize that what our health professionals do in the Indian context is quite remarkable work. So actually to provide them with technology which could make it even better and which could make it even easier for them to do their work would be truly remarkable, and can truly deliver scale, healthcare at scale. And equally, the data and information that it generates is something which can be used in ways that you cannot even imagine. Like the PM Ayushman Bharat scheme, the state where I come from and where I served, we had a health insurance scheme, I think probably about 15 years ago or so, when it was introduced, and the volume of data that it generated in terms of the kind of diseases or the kind of conditions people suffered from, which hospitals they went to, which regions they came from. And there was a time when we were doing a data analysis on how exactly these flows are working. The insights it reveals to anybody who's in the policy space is tremendous. And the kind of decisions that you can then make based on the analysis of the data in terms of where you need to locate health facilities, where you need to strengthen them, where you need to build awareness in terms of where the facilities would be available, all of that is a huge opportunity and clearly helps us deliver services better. And I think that's another critical element of what needs to be done and what would come out of this. We're extremely happy as the India AI mission to work in the application space, both with NHA and other institutions under the Health Ministry. We've worked with ICMR, we've worked with CDESCO. We've worked with a number of them, and it gives us the opportunity to actually put out their solutions which can truly make a difference in healthcare and at the same time be commercially viable in terms of something that people can use and people can go forward. Likewise, we really welcome this opportunity to work with the CoE on healthcare. There are 4 such CoEs across the country which the Ministry of Education has set up, and the opportunity to work with them and the opportunity to actually collaborate in delivering better services is something which is significant. I have only one appeal to the CoE. I think we need to more closely converge and coordinate our activities in a way that we don't keep rediscovering the wheel, especially in terms of applications and so on. There's a fair bit that fair bit that can be done by the applications pillar and vertical under the India AI mission. Given that these COEs are located in very, very eminent institutions like the Indian Institute of Science, the possibility of actually using these centers to do higher order work is something that we would really welcome. And the possibility of collaborating on building more models themselves, foundational models. Not all of these models need to be large language models. They can be small language models. They can be models focused on this. This afternoon, you're discussing with some of the models which have been seeded under the India AI mission. And there you do have specific SLMs which work on things like studying patterns of EEGs in order to detect abnormalities. There's drug discovery, which is another important element of what is being attempted. So models of that nature which can be built quickly and where we can sort of collaborate. That's one way in which I think scarce resources and resources which are available in the country can be utilized more effectively, and we can actually leverage each other's strengths to actually deliver much more impact, deliver much more as to what the society actually needs. So coordinating these efforts and collaborating on these would be, I think, significant. And you know, the ministry, MeitY, has a very, very close relationship with the Indian Institute of Science. There are a number of programs that we already support here, a number of ways in which our relationship moves forward. And clearly, between the India AI mission and the COE on healthcare is one more relationship which we would love to actually work with much more closely. And this particular center, and given the work that you're already doing on data and data exchanges, and that again is an important basis of what needs to happen, and that is also work with which MeitY is associated, I think the possibility of producing something truly world-class out of this, the possibility of really looking at AI as an overlay on DPI in order to deliver these services much better, make more data available. The point that Mr. Banwal was making already, that the data doesn't get used adequately. The possibility of using it better, the possibility of using it within an overall privacy-enhanced environment is, I think, a truly remarkable possibility that we need to work towards. Any assistance, whether in terms of, you know, regulatory or legislative-related help under the DPDP Act or otherwise, or whether it is any other sort of you know, infrastructural support, is something that MeitY can certainly provide. And that sort of policy assistance would certainly be available from us. But I think truly today's event represents one of those events where efforts converge, and more of these efforts are needed to make sure that we truly deliver to the possibilities that AI offers us, and while at the same time being extremely cognizant of the risks of using AI. Some of the risks were highlighted by Jyoti in her opening remarks, and there are more risks which keep coming up, and we are acutely conscious of that, and which is why we have an entire pillar, entire vertical, which deals with the safety issues. And we would be happy to take work forward on addressing these safety issues as well. So on each of these areas, I think there's considerable synergy between what is being done across these three ministries, and I'm very, very happy that we are all present here jointly on the stage to represent what needs to go forward. And this is work that we can continue to push forward and not just stop with this hackathon. Thank you very much for having me here this morning. I think it's an extremely significant event that we are participating in. Thank you.
Thank you so much, sir, for this insightful keynote address where you have clearly laid down the need for a trustworthy and scalable AI for public services, as well as interministerial coordination and convergence. Now, as we come to the closing of this opening session, I would request Dr. Sunil Banwal, CEO, National Health Authority, to present a token of appreciation to the chief guest, Sri S. Krishnan, sir. Now I request Ms. Jyoti Yadav, Joint Secretary, AB PMJAY NHA, to present token of appreciation to CEO NHA, Dr. Sunil Barnwal. And to Professor Govindan Rangarajan. Ma'am, this is also there. See you, sir. Ladies and gentlemen, we'll now break for tea. The tea and refreshments are being served on the third floor for all the participants. And the dignitaries and panelists are requested to proceed towards right on this floor itself. And we'll gather exactly after 15 minutes. It's 10:49. So I'll request everyone to be here by 11:05. Thank you so much.
check, 1, 2.
Auto-Adjudication Hackathon 2026. Little bit into
शुभं कुरु त्वं कल्याणम्
healthcare. India's healthcare AI ecosystem is entering a phase of meaningful scale and maturity. This ecosystem consists of the foundation models, SLMs with vision-based diagnostics, voice and conservational capabilities, and the base of it lies ABDM, the digital public infrastructure for health. The question this panel will address is a simple one. How do we get these AI solutions actually embedded inside India's health workflow at scale? We have on the panel some of the most thoughtful builders, policymakers, and researchers shaping that answer. Let me first invite our chair of the panel, Shri S. Krishnan, Secretary, Ministry of Electronics and Information Technology, Government of India, who will be chairing this panel. Sir, may I request you to come and take the seat on the panel? Now let me call the panelists on stage who are leading voice in healthcare AI in India. First, we have Mr. Ankit Modi, Chief Strategy and Growth Officer at Cure AI, where he has been shaping AI product to escalate diagnostics and improve treatment for TB, lung cancer, and stroke. Next, I would like to call on stage Mr. Chandrasekhar K, founder and CEO of Forest Health. He's working on the mission of eradicating preventable blindness by creating innovative products such as Trinentra. Moving on our next panelist, we have Mr. Narayana Rao Sripada, founder director Swasa. He has been focusing on building digital health solution for respiratory diseases based on respiratory sounds. Lastly, for the host institution IISc, we have Mr. Raghu Dharmaraju, CEO at PARC. He's building at PARC into a prior AI and robotic innovation factory with a strong innovation portfolio for health as well. Lastly, let me invite the moderator for the panel, Shri Kiran Gopal Vaska, Joint Secretary and Mission Director, ABDM, National Health Authority. Shri Vaska is playing a critical role in advancing India's digital health ecosystem and strengthening technology-driven healthcare initiatives at the Ayushman Bharat Digital Mission. Sir, may I request to kindly take a seat. A very warm round of applause for our panelists. Sir, over to you now.
Thank you. A very good morning to everyone. And after a very enlightening inaugural session where we've heard from Secretary Mighty, CEO NHA, Jyoti, and the Director IASC, I mean, one question that persists vis-a-vis AI in healthcare is how do we really scale it up? How do we really start using AI in our day-to-day healthcare delivery, both in the public and the private sector, while ensuring safety, safe and ethical use. So, as you can see, the panel today consists of a diverse set of representatives from both in the public and private sector. And our objective is to examine from the perspective of health AI builders as to what is required to translate the present capability of Indian healthcare AI ecosystem to reach the impact for patients across the country, both in the primary, secondary, and tertiary care, in both public and private institutions, in both urban and rural geographies. The panel will also try to consider what is required for healthcare providers, regulatory bodies, government, and builders themselves to ensure AI products move from proof of concept to routine use in care delivery. So the objectives would be to surface from the builder's perspective these key institutional and operational barriers, to assess the relative suitability of different model architectures for specific public health use cases, and to identify measures required from ABDM, the government in general, and other public institutions to enable effective integration into health systems. Without further ado, I request the chair of the panel today, Dr. Krishnan, to kindly give his opening remarks on what he thinks the government is doing or give his views on this current topic. Sir.
think to be very fair to the audience, they've heard enough from me already this morning, so I wouldn't like to belabor them much longer in terms of what on this particular topic immediately. But I think it's more valuable and important to hear from the practitioners and people who are actually using this to understand how they are doing it. And to the important point that you made, from a proof of concept or a pilot, how do you scale it up and what are the constraints that they face, is I think the important thing. And what government can truly help with is scale up, and that is where government's strength lies, and I think that is truly what we have done in the case of DPIs. So in the morning, earlier in the morning session, you did hear me on some of the approaches we've had and some of the work that we have done in that space. And we have the AI mission, and we have the various other initiatives fundamentally to help with this. And we would be very happy to hear from those who are in the field and working in that space in order. And I have a full team which is here from the AI mission as well, present. So we would love to hear from you and hear from you what the challenges are and what you think we can do better. And probably I'll come back and respond if there is anything specific a little later. Thank you.
Thank you, sir. So in order to just fire up the conversation, I just want to pick up the thread from the inaugural session where we talked about LLMs versus small language models versus very purpose-specific implementations. This is a question that I just want to pose to all the panelists here to just hear your perspective, because you all are coming from different experiences, both in terms of the time in which you've spent and also in terms of the solutions. Some of you are doing specific solutions for a specific issue, or some of you are building data sets. So I just wanted to understand from you what you think is the way ahead, or what your approach is towards this large language models versus small language models versus very purpose-specific interventions. So we'll start from that, and maybe from Mr. Ankit Modi to hear from your perspective. The idea is like we'll have quick remarks from all of you on this, and then I'll ask each one of you specific questions, and towards the end again, I'll ask some common questions to all of you.
Thanks. That's a very relevant question. I was actually discussing this same topic with Benjamin Mann, who is one of the co-founders of Anthropic, a couple of weeks back when I met him, about where like sort of models like Mythos or Claude should be used, and where like sort of small language models are actually proving to be more useful. And one of the things that I remember discussing was that in very local context, in a particular language, on a particular disease. For example, if I want to help a healthcare worker on malaria in a small country in Africa, or in a like sort of very specific dialect, you can actually distill learnings from the bigger models or the large language models, and then use that SLM where it can work on a phone, offline, without internet, but then you have to put in the right guardrails around it, because that specific model is trained for a very specific task, and it will perform that enormously well. What you cannot ask it is who is the president of United States, right? Because the model is not a general model. It has been trained on a particular task, and if you can put it enough guardrails around it, that if any particular questions is being asked to that model, which can be just like sort of negated by saying that, okay, this is not what I have been trained for, please keep the queries concentrated on malaria, right? Their SLMs are very, very useful and are even preferred. And I'm not saying that, like Anthropic is saying that. Where large language models come in is when you want to have analysis done on varying context, right? So small SLM on malaria in a particular dialect in a particular country, then an SLM on tuberculosis in another state or another country, various diseases, various context, various dialects. When you want to bring all these learnings together to a central platform and then have someone analyze this. And this can be multimodal as well, not just textual data. It can be imaging data, it can be video data, and all of that, right? So they're like the large language models, especially the ones that we call as frontier models, are extremely useful. But if you try to deploy Claude in a village where access to internet is broken, and you are expecting a health worker to ask a question to a patient, and he's just struggling that the model is not working, or reply is not coming, internet is not working out, then it's futile, right? So offline, local context, SLMs, broader context, varying kinds of data, analyzing on top of like sort of, I think, yeah, learnings from all the SLMs going to an LLM is the like sort of ideal case scenario.
Thank you. Raghu, you are at Art Park. You have been in this area for nearly 15 years or more perhaps, or even more. And you are building startups, and you're also supporting other startups. What is your input on this in terms of coming from an academic institutions where the center of excellence is situated, and Art Park is doing excellent work, especially the MIDAS related work that they're doing. So we'd like to hear from you.
Sure. On SLMs, I think it's a matter of time. We have to kind of start picking what I would say battles small enough to win but large enough to matter, right? If we try to build a broad LLM across healthcare for India, probably we will not succeed overnight. However, if we say, hey, this is a very, very narrow area and this is an SLM, what's the point of it? The point is an SLM is an infrastructure element that allows you a foundational element that makes raising the next pillar easier, right? So I think going by disease verticals, languages, these are all useful ways to limit that and create SLMs. I'll give you an example of India AI Mission's Foundation Model Challenge winner, Zentique. They are building basically scientific foundation models for engineering design. But that doesn't mean they are going to try to solve it for all areas of engineering at once. They have prioritized certain areas such as thermal analysis, computational fluid dynamics as starting points where they see enough diversity of applications, but a relatively narrow scientific field that they can actually build such scientific foundation models and go into software such as ANSYS and SolidWorks. I'm using this as an analogy for what health also needs to do. Data will become a very important element of this. We can, I don't know if you want to get into the data discussion now, but a key point I want to make there is if we want to build these kinds of SLMs, they will not be built simply because of the quantity of data that we have, because it always rains in Bangalore and yet we don't have enough water this summer perhaps. So it will come to the systems we create, not one-time bucket or one-time bottle.
Thank you, Raghu, for that. Narayan Rao Garu, you are the founder director of Swasa, which works in this very specific area of respiratory ailments from the voice or cough. And in this context, I would like to hear your views on this whole SLM versus LLM versus edge computing devices, which could even be my phone debate.
Yeah, thanks. So actually, as sir mentioned, we have a product called Swasa, which primarily uses cough as a marker in detecting the underlying respiratory conditions. All that what we need is a smartphone. We don't require any infrastructure or the hardware. I mean, sir, any other hardware. So, I mean, the task what we have is really in identifying if you have any abnormality in the lungs and whether it is because of some obstruction in the airways or lungs not getting expanded properly. And also narrow down, like maybe there is some kind of a chance of having COPD, asthma, or a tuberculosis. So for this kind of an application, definitely SLM is more suited. But as Raghu mentioned, that's definitely a starting point. But if you will look the patient from the patient perspective, he requires some kind of decision which is meaningful to him to act on. based on the data what he is providing. I mean, the data can be cough, or it can be an X-ray, or it can be even an interaction with the patient and so on. So basically that's where the LLMs or the foundation models really bring into this. So when we are designing our SLMs, we need to keep in mind that, don't narrow focus, and yes, you need to address the specific task, but at the end of the day, you have to make sure that you are actually getting integrated your model into some of the LLMs like MedGemma and all. So that's where the real value of what you are developing comes in.
Thank you so much. We have Mr. Chandrasekhar, founder and CEO, Forus Health. The same question to you from a business perspective.
Yeah, first, see, we started working on avoidable blindness as a mission, and we continue in that. And so the first gap what we found was medical devices. So we are not an AI-only company, right? So we are a medical device company. So when we start making these retinal cameras to identify retinopathy or ROP, and we today make products and sell in almost 85 countries. See, when you take a problem from that side, we always look at it from an implementation point of view. What is a gap? Okay, and start building models around that, not the other way around, not build and then try how to fit it. So, because you have to become a monetizable company, whether you are making AI or product or solution, whichever way. So, for example, I'll take this year Kumbh Mela we screened, last year Kumbh Mela we screened 25,000 people for eye comprehensively in that kind of a. So now that patient is going to be available to you only for that 1-2 minutes, and you take an image, and that image is not good enough for a diagnosis, let's say by AI or by a doctor, then the patient is gone. So you can't get him back. So there, the image gradability, the image what you took, is it gradable or not? Can you identify a disease or not? You need a local kind of an SLM, which is very critical because you do it on the edge, and then and there the operator knows that he's taken an image which is not good enough, so he retakes the image. But when we go into larger problems, so we are almost looking at multiple things. So when we are taking eye care to primary care, we're not just looking at retinopathy, glaucoma kind of eye problems, but we are also looking at, can I use retina and identify a cardiovascular risk or a chronic kidney disease, because it is non-invasive and the accuracy levels are also good. So then you are computing multiple things. You are doing an image analysis, you're also taking data of prehistory, you're looking at other parameters. You need a slightly larger. So we are taking the LLM models. In fact, we are doing the vision language models, VLMs, because it almost can give you looking at singles, because CNN models are comparatively very disease specific. So it is saying only for DR, only for glaucoma, only for macular degeneration. But when you get into these, you can actually do one retinal image, which can actually give you like a report on what are the various things it is seeing in the eye, as well as what is the systemic inference it is making out, whether you see this person to be at a cardiovascular risk 7 to 10 years. So that's how we will kind of look at it, purely because it comes from implementation, because that's the setting we see, and that's how we have to configure it in order to make this work.
Great, thank you. Sir, feel free to come in as and when, and whenever you feel you'd like to make a comment, sir.
I just had one thought, and I think what all of them are saying, and from the field experience, is something that we also understand in terms of the input that we are receiving, that it's not about one model, it's about different models, different use cases, different ways in which we do this. So actually how to orchestrate this whole thing, or how to put the whole thing together, and this is an approach which during the AI summit, actually at the initiative of the Prime Minister, that was put together. This is at least diagnosing for people who can talk about their diseases and who can tell them what the problem is. I think the question that the Prime Minister asked Nandan Nilekani was, how do you do it for animals who can't actually speak? And that was the origin of the Sarla Ben app, and something which got developed within about 3 months, 3 weeks literally, because the data was available with Amul, or it would be available also with, since we are in Bangalore, with Nandini. So the data would be available. The idea is to build an orchestration layer, and then you can use a multiplicity of models. You're not then confined only to using a small language model or a large language model. So you use a multiplicity of models at the other end. So you kind of, from the data, you try and infer what is the question that you're trying to ask, and then use the reasoning ability of the model to come out with an answer that works. And clearly, even in terms of human diagnosis, and to your point that you needn't build a complete solving all problems at one go. So you can modularly build this out. Probably that's the kind of architecture which, as part of the CoE here in IISc and as part of the efforts of NHA, that's probably the direction that we need to take in terms of, can we replicate something along those lines? We are trying to see whether an orchestration layer is something that we can work on as part of what we are doing in the India AI mission. We'd be very happy to partner with this, and I think that'll be a useful way forward, taking a cue from all that, what they have said in terms of the field issues are. Because sometimes there are interlinkages. From the retina, you can figure out that something else is wrong. Sometimes from the way that people breathe, you can figure out something else is the matter, not necessarily a respiratory infection. So the linkages can also be worked on. So that might probably be a useful way forward. Thank you.
Thank you, sir. We now move to the next question, to a very specific question to Narayan Rao Garu. Basically, your solution has been there for some time, and you are also doing a pilot with Andhra Pradesh. What I would like to understand from you is, what breaks first when you go and try to implement something in a state? Pilots, yes. Then what happens? Why do we not see these really solutions being used statewide or countrywide, or what are the barriers you are seeing there in terms of scaling up the solutions that you've built? You know that they are good, they have been tested in many scenarios. So we'd like to hear you on that, please.
Yeah, thank you. Interestingly, we are one of the startups who got significant support from government. I mean, we have received multiple grants from MIT, and we have received multiple grants from DBT as well. But unfortunately, when it comes to deploying our solution with the state governments, we are still struggling. I mean, multiple things. One, of course, to his first point, the barrier, what did you say, the first? Yeah, what breaks first? I think the first fundamental thing is, it has to be integrated into the clinical flow. If it is not integrated, then obviously you don't, I mean, however good your solution is, it will not see the light of it. I mean, basically we initially developed with an assumption that it can be used by a doctor for screening people who are really visiting the OPD. But somehow it's not really working out that well, because doctors, first of all, they are very busy and they are not very eager to really adopt these kind of solutions. I mean, they take significant amount of time before they are really practicing it. What we realized is that I think maybe the most value of our this thing is with the field health workers, who can really go to the field and then do the screening as part of the community screening, and then based on the output, they actually refer the patient back to the clinic. I think, so now it took us some time to really figure out that the flow integration for us is really with the field worker. Now, once we have understood that, then of course, we are now actually doing a pilot with the AP government, where they have given us an opportunity to do the screening in one particular district, and then subsequently we are hoping that they actually give an opportunity for a wider deployment in the entire state. But prior to that, the major challenges what we have faced is, whichever state we go, the first question they ask is, where did you do the pilot? I mean, this is completely a new innovation, which is developed in India. I mean, someone has to come forward and give us an opportunity. I mean, right? Then only we will be able to do a pilot and demonstrate the result. I mean, if you are looking for some evidence which has already been deployed somewhere else, then where is the chance? I mean, that's really a very big problem. I mean, I am very happy to say that, with AP we could actually solve that, and they have given us that opportunity. And the other thing is we are software as a medical device. They'll ask even for pilot, even though, generally state government may not pay us anything for the pilot deployment, but they get into pricing discussions and say, what is the price for your device? I mean, there is no device here at all. I mean, basically they say, do you have, a GEM registration for your, cost including for your device and all? No, we don't have. We come under primarily software as a that's all. But this terminology is not understood in the public health ecosystem. I mean, they feel there has to be some physically something is available, then only it can be actually charged. That's another really very big challenge. So one, of course, doing some showing an evidence that it has already been done, and other is having a physical device attributed to it. These are the two major challenges. And the third challenge is the expectations in terms of what the device can offer. I mean, basically, see, we are a screening device. The idea is to identify people who are actually, detect the conditions early. I mean, missing those millions which are getting missed out. Okay. So here, yeah, accuracy. Agnostic device when you are actually talking about a screening device. But people come, but when you say that you are detecting, then if you are going to miss out these people, anyhow you don't have anything else there in the market. I mean, right? Where is the question of not picking up someone? You are actually picking 70%. Maybe you are missing out the 30%. If you don't do this, even that 70% is also getting missed out. I mean, right? So huge expectations on the validations. I mean, basically, I think people need to understand that depending on the use case, you need to look at the advantages and disadvantages. I mean, in terms of what a device can bring in at some cost, that's fine. But if the advantages are really going to be strong enough, then I think you should come forward and take it to the deployment. So there's a lot of expectations on the validation and accuracy. And of course, the third one is really, especially in our case, we have two challenges. One, cough as a marker. I mean, that itself is not known to the community that well. And artificial intelligence on top of it, that adoption is also in the so we have two challenges. So for us, it's like, to provide, to evidence in terms of multiple validations. People ask, did you do validation at community? Did you do validation at tertiary? Did you do validation at secondary clinics? I mean, basically there's no end to it. There are so many expectations on the validations and all. So, essentially that's generating, completing those validations and generating evidences, especially through highly reputed, journals, articles in highly reputed journals, and saying that it is really working. That addressing that is another really the challenge.
Great. So basically, generating evidence, finding a foothold in the form of a pilot, and then trying ways to scale it up after that is an issue. Raghu, I would like to come to you now. You are located in IASC, where the Center of Excellence is present. While this embedding of AI into workflows is a problem that has been highlighted by Swasa, and also the validation part. Unlike drug discovery, or where you do a clinical trial and say, okay, this medicine works for this ailment, AI, you benchmark a solution and say, okay, this is so and so, it is accurate at a certain level. The score is X for, let's say, if it is a binary classification, if F1 score is so and so, or if it is a language model, or if it is a OCR model, you find certain variables. But what happens with AI is, it evolves over time as it starts learning. So, I mean, to begin with, what additional barriers do you see in terms of developing more models, bringing it more and more into public sector? And what future challenges also you see once we start embedding it in terms of safety and making sure that the solutions start working, they don't start breaking after we have scaled them up?
Perhaps a useful way to look at this is through the lens of what's the life cycle of AI, right? Very broadly speaking, there is a phase of research, a phase of development, then there is some sort of a gate of validation, ultimately, deployment and monitoring, right? So the kind of challenges that I was just speaking about now are in deployment and monitoring. In deployment and in that phase, as you come there, you need some way of distributed or decentralized validations and adaptations, right? Otherwise, you will end up constantly running to a central node or one node saying what's been done, one place saying what's done there is not valid here, right? So you need some centrally aligned but still distributed mechanism of validating and adopting these things. The point of procurement and pricing was already mentioned, right? So I'll skip that. Third is, of course, is monitoring and updating, right? Because it's not a one-time deployment. It's a fundamentally an iterative sort of solution. So this is on the deployment end. So similarly, you have challenges in the research and development side too, right? So a lot of it has to do essentially from going from a linear mindset to iterative mindset. Otherwise, what you will do is you will build things in a lab that doesn't translate out well, right? Unless you have ways of bringing data that is rooted in deployment and use case, you will find that your research and development lands too far from what is required on the ground, and that ends up being a big breaking point, right? But in a setting that typically thought of development as linear, there's a lot of mental model breaking and institutional capacity building that has to happen to do this, right? Second is, at the end of the development phase, because in research you're trying to find what patterns work, what patterns don't work as a proof of concept. In development, you have to replicate that again and again. So now you need different type of data. You need data of a certain volume for a particular use case or a set of use cases. Now this is different, right? It's not simply that you give me lots of data with lots of variables. You already know 3 or 4 variables have most of the signals, so to say. Now you're trying to replicate it. That's a different type of data system, right? So this, and so in all research, development, validation, adoption, right? You need different type of data systems. And I think that is very fundamental to do. And to have those data systems, yes, we need DPI. But I think perhaps more importantly, we need the underlying policy and institutional capacity to actually do that, so that DPI can actually be embedded in and we can actually bring the data together.
Thank you. Thank you so much. Now I'd like to move to our next panelist, Mr. Chandrasekhar. You know, until now, our discussion has been how do we bring AI into the public sector. But as Government of India, MITI or NHA or Digital Mission, we are saying we want to create a digital health ecosystem that spans both public and the private sector. And since you are from the business side of it, I also, and for example, I wanted to understand or give us your insights on what are the barriers that you find when you want to go and try your solution to a private entity, a hospital, a lab. Because we've seen that they are very quick on adopting machines, MRI machines or CT scans or even new things. But how about AI? And how do you think government can help you in this? For example, all of us, we want to buy an AC in this summer. We'll see 3-star hai, ki 4-star hai, ki 5-star hai. So is there something like that you think can help? Or what are the barriers you think you have? So that we also understand and see how we can partner with the startups and existing AI companies in this, vis-a-vis especially the private sector.
Yeah, thank you. So I think we have experience both on the public and the private sector. So one thing what Narayan Rao said is very fair, that we realized this long back, that if you have to ultimately deploy it, it has to be a scalable deployment. It can never be a pilot, anything, right? So for that, you have to be sustainable. In the sense, you'll have to deploy it and make money, and so that you deploy tons, right? So fortunate part for us, we had something very tangible, in fact, very big. So 5 lakhs worth big equipment, so people feel they are getting something. So we actually deployed a large model with Andhra Pradesh government way back in 2017-18. So the Mukhyamantri AI Kendram actually was deployed across 115 community centers, where obviously the platform and the AI did not have monetization, but physical hardware had. So how internally we priced it became easy for us, right? But they didn't feel it because they knew the value of this product was X, so they got it X, but we also bundled so for us, deploying that and proving that was an important part. And because it was top down, it was actually pushed to the people to use it, and it became a grand success. So that was the first point. Now, when I go to private, the same thing works. So what we also started to do was, we started to do screening as a service ourselves. So we went to corporates, we went to camps, we went to everything, and we did almost close to 1 million eye screenings, which is at a particular price point. Let's say 300, 400, 500 rupees for a person, which is paid by the employee or an institution or by philanthropy, whoever it is. So there, we actually initially did it on an assist mode. So there was AI and there was a doctor. So we were able to actually give a data to your question on 3-star, 5-star. So in their environment, they could see that AI graded X, doctors graded Y. The sensitivity or specificity equivalent to that was reasonably high. And obviously it picked up over a period of time. The advantage we had was we did not have, to sell this, because it was anyway the last mile was the doctor signing. But in the whole process, we had AI getting validated and getting validated over actually all the use case conditions. So it is not a test like, it's not tested on test environment. It is multiple operators, multiple light settings, rural, urban, poor, rich, all of these places. So in private, it started building that credibility. So we were able to translate that when we deployed it in Karnataka, where we were able to deploy it. So I think the most important thing is the way to kind of build these things. Some of us may have that luxury because we made hardware. It was easy for us to kind of bundle it. If you are a AI-only company, how do you survive? So, right, like you can't keep it doing free. And general behavior in India is software to free, right? De do yaar, kya hai? Hardware, physical, right? So that is obviously, so in fact, when I started, see, our passion was the retinopathy business, right? And after 5-7 years, we realized that retinopathy, actually nobody cares. Even though the prevalence is high, nobody cares. So we started bundling with refraction. So when we did and gave a spectacle, they got something tangible. So in that process, they got refraction done. So you have to actually manage, I would, more than technology, more than government, private, I think the biggest takeaway is you have to integrate it behaviorally, whoever it is. If you integrate it behaviorally, then you will sustain and survive. All other things you can pick up, right? But you have an amazing model, but poor business model, 2 years down the line, we'll have to, look for another job. Unfortunately, that also is not available now. So,
Thank you. Thank you so much. Now I come to one very critical aspect of use of AI, safety and ethical use. And my introduction to Cure AI was in one of the events where one of your team members came to the stage with a suitcase. Said, okay, this is our AI-enabled STED, this is our AI-enabled BP reader, this is our AI-enabled different devices. So while by using these devices, you are collecting a lot of patient data, and also you are determining how the treatment pathway of the patient is going to be determined by this. So how do we ensure that this data is safe in first place? And then how do we also ensure that the pathways that are being defined by virtue of these devices are also clinically validated and they are safer to use for the patient? And since you are, I believe, working in around 85 countries, what is the kind of landscape that you are seeing which we can implement or replicate in our country for that? Of course, we have DPDP and others, but then what in addition we can do?
No, on the data side of things, there is a huge difference between training data and then data on production, right? So on production, I mean, when you're collecting these kind of data sets, you have to ensure that it is completely separate from patient identifiable information. And that is where like bodies like HIPAA or CDSCO and the Cs and FDAs of the world help you like sort of set up the right processes so that those questions are well answered. But if I can take a step back, the chief problem when a technology is in its infancy is not safety, reliability, it's just market creation, right? And I want to explain that point with two examples. First is like sort of, if you look at Silicon Valley, early 60s, 70s, when Intel was just launched, 100% of the chips were bought by the US Defense Ministry. And then it became 50% after Apple and Microsoft launched, and then it became 20%, then 5%, then 1%. That was from the last century. If you look at the last decade, a similar technology is space tech. Almost all of the revenue that SpaceX generates comes from NASA. Now they are diversifying into data centers for AI companies and all that, and it will have the same journey. We see similar examples in India as well. Space tech companies in India are thriving. Why? Because ISRO is demanding high quality products as a customer. They are not writing grants to promote innovation. That is also important for exposure for youth and the eminent institutes of the country. But ISRO has become a customer, and because you are paying money to get something, you demand safety, you demand reliability, you demand high quality products. All of that, then companies have to solve if they want access to that market. And I think AI has to go on a similar journey over the next few years. I have personally met almost around 10 to 15 health minister and health secretaries across different Indian states, and have been like sort of trying to make this point. Everybody is very, very supportive about the kind of impact that it can create, but there is just no precedence to procure AI, right? So over there, like, I mean, the market creation, if government can do that for the first few years, I think private players will come in and like sort of all these other concerns will like sort of get solved on their own. Over there, like, we have done 2-year pilots in Goa, we have done 3-year pilots with BMC. It's just about, and everybody is saying that if that state does it, we will also do it, right? And it's just about creating that one single precedence, after which, and we are very close. Like, I think both in central governments and state governments, we have gotten enormous support. But the fact is that we have been able to invest those 1.5 or 1 years of this meeting people and like sort of educating them about what kind of impact it can create, because we have also had alternate sources of revenue to fund this entire 1 year, 1.5 year cycle, right? But this pattern is consistent. Like, for every new technology, the first source of like sort of customers are actually governments, and then they diversify. So if we take care of just that, I think everything else should fall in place.
Thank you. Thank you for that. Sir, I need your, I was looking for your guidance on this, sir. What Ankit Modi has mentioned is a very pertinent point, and we go back to Mariana Mazzucato's The Entrepreneurial State, which shows how iPhone is actually a combination of inventions that were actually funded by DARPA. But the thing is, then we have a very good example in space, the Antrix. So, sir, do you think we should have an Antrix-like model for AI in healthcare, or for that case, AI in general, sir?
No, I think, you know, they've raised the real issue. See, up to a stage, what government supports, it's interesting that in the government context, the Constitution permits us to give grants to anybody, right? So if there is somebody who comes up with an idea, or somebody who comes up with a request, you're making an outright grant, then you don't have to go through any procurement process. You can sort of evaluate a set of grants, and then it's like a beauty contest or something, saying, okay, I've evaluated this set and I give a grant to 1, 2, 3, 4, whatever. That is very useful up to the first stage, in order to enable them to come up to a particular level, in order to come up to a particular thing. You are trying out a new idea that works, and that's precisely how it's been working thus far in this space, in terms of government making these grants which we can give. So most of in the hackathons or for applications and so on, we're just giving outright grants. Likewise, in the case of the models which get built, the small and large language models and other models that are getting built, we give them outright grants or outright credits, and then some of it with the option of converting into an investment. So that's how it's operated. Now we've reached the next stage. It's becoming a viable project. At that stage, when you sort of give some degree of exclusivity or some degree of this is the application that I choose, then there are two routes which you can follow. Most of us are familiar in the general financial rules. There's that sole source procurement because you believe that this is something which can be done. That again can work up to a point and where you are clear that there is nothing else which is available or nothing similar which is available. But you can't do it beyond that stage because then naturally somebody else will say, of the four people sitting on the stage, he will say, no, mine is equally good, so why aren't you doing mine? So which is why we need to have a set of criteria which define how the procurement will be done. The complexity in the case of AI is it's evolving. I mean, you can't set specifications very clearly. You can't set commercial conditions so clearly so that a priori you define this is what I'm buying and a priori you define this is the price. Both what you're buying and the price for what you're buying could change over a period of time, within that limited period of time. This is precisely the issue we are grappling with right now. And we are working in MeitY on what should be, how do you procure AI is the question that we are really dealing with. To figure out how is it that you can define something, how do you, after the initial stage, you have to leave flexibility. Otherwise, then the latest development you cannot capture. So you have to leave flexibility to update something. In the process of while you are implementing the contract, you have to leave enough flexibility to change some of the quantities, change some of the specifications of what you need and what will be supplied, and likewise allow for additional payments to be made on some negotiated or some transparent basis, because ultimately we have to remember, since we are spending public money, it needs to be transparent, we need to be answerable. So this is a question we are grappling with. The same question that we are grappling with in terms of providing compute. We initially started with, okay, let's try and make it as broad-based as possible. You're not specific to one company, you're not specific to one entity. We try and make it available to all and everyone supplies, and based on how much is bought, you do it. But then if you're in that procurement model, the people who are making investments need some certainty that at least a substantial portion of what they are offering will get procured. Otherwise, how do they make the investments? So we have to give them that certainty as well. So this is a key question, and I think this is something which our team is working on at present. But we need to evolve this quickly because, as is clear from the discussion here, this is a space where that activity needs to be concluded quickly. We have some pointers in how we can go forward. A basic level requirement, a basic level specification, or you could price it on the basis of, look, this is the outcome that I want from you, and if you deliver this outcome, tell me who's the person who gives me the lowest price. So we can do it on the basis of an ultimate outcome. But there again, the problem is that the outcome itself, in certain cases, you can deliver more. I mean, you can deliver beyond what was originally promised. And somebody says, why are you defining the outcome so narrowly? We can, like your example of, I look at the retina and then I find a number of other things. So I can deliver a bouquet of benefits, and so why can't you buy all that? And which is half the problem of the products we buy. Privately, when you buy your phone, probably you use 10% of the features there are, but you pay the price that you pay simply because there is an element that you want, but what you use it for is probably a much smaller proportion. So this is an issue which we actually need to address, and which we are addressing right now. I take away from this discussion that there's a greater urgency to actually find this particular solution. And it is work in progress, and any suggestions from all of you also are welcome. Because, our support thus far, as I said, we are prepared to give you grants, we are prepared to support you, we are prepared to support you for pilots. But once you go beyond that, it needs to be a procurement model, and in a procurement model, all of these challenges are there. And it's not just in the health sector. I'm facing the exact same challenge in the defense sector. Precisely this problem, saying the defense ministry wants to sort of source from a particular entity, then there are about 4 other entities who come and say, we can do the same thing, why are you going with X? So this is an issue we need to address. Our initial way of addressing it is to address it, it's more as a research kind of project, so that, as I said, we are free to give grants, so nobody can question us for giving grants. So it's easier to do it that way to begin with, but we have to solve this problem. It's fundamentally about defining what we are procuring, and it's defining the scope of what we are procuring, and how do you adjust for changes and upgrades within this intervening period. Any thoughts and suggestions in due course, not just immediately, are also welcome on how we take this forward.
Thank you, sir. Now we come to the last question again, which is a common question that I want to pose. The Ministry of Health and Family Welfare, Government of India launched SAHI, the strategy for AI in healthcare for India, during the India AI Impact Summit. And now the government, and it had a set of 32 recommendations on how to go about data and governance, how to build capacity, how to do market enablement, and there are these 5 pillars in that. Now, currently, the government has constituted a new committee to build a roadmap on how do you go about implementing those 32 recommendations. And I want to hear from each one of you on what you think are the main things that we made points that could go into this roadmap in quick 2-minute interventions, and also what you think should change, or you want some change in the next 1 year that could actually help you leapfrog into getting your solutions embedded, or getting your solutions moving and scaling up much faster in a short time, so that we can show some quick wins for our own self-encouragement, and also to learn from that process and take this roadmap further. Again, we'll start from you, Raghu.
I will actually jump off of what Sri Krishnan said about the procurement, and I think there are some quick wins there. I keep thinking back to, obviously, chest X-ray for TB as one of those things, right? In some sense, it's both a success, and quite honestly, in some sense, it also is indicative of our collective failure on certain aspects, right? Because the amount of deployment we should have seen by now, given that we thought the algorithms were ready at the end of 2017-18, is not at the pace at which happened, right? So the key intervention I would recommend here is pick a few use cases where there seem to be a lot of solutions, but how do you unlock the procurement? It comes from actually the concept of target product profiles for specific use cases, right? I'm not saying we go that narrow, but at least for a bunch of use cases, we will have to create what are the performance requirements that we generally expect on the field. And then we will have to figure out some ongoing distributed mechanism of such data coming together, so that every time there is no bespoke validation. The frustration of innovators is that after you do your publications, your Lancet publication came out 2020, 2021, right? 5 years after that, you're still saying, how does a particular state procure? Which means clearly that great Lancet paper is not good enough for a particular state or a health system to adopt. So you need centralized alignment on what the data set requirements are, and have some mechanism to keep collecting that data in a distributed manner in respective health systems. Without doing that, we will be stuck in the era of one-time or one-place validations, which is a fallacy for AI, right? So to me, that would be the big thing. But let's not boil the ocean. Let's pick a few things where there are lots of folks already competing with their solutions, and let's unlock a mechanism like this, right? Working with the right stakeholders.
Narayan Rao garu.
Yeah, the recommendations from my side are, it was related to somewhat earlier discussion about the safety. Actually, in Andhra Pradesh, I'm very surprised to say that, the place where we are doing the screening, everybody has ABA ID. 70% of the people whom we screened have ABA ID. Okay. And, we are actually capturing some ID using our own mechanism. And then, we also ask patient about their age, gender, and all kind of information. And yeah, we ask the consent and we make sure that it is safety and HIPAA compliant, DPDP compliant, all that we'll take care. But if the whatever the innovation frameworks or the SAHI which is getting developed, if those people, that frameworks can ensure that by using some APIs, if a person enters the ABA ID, we get the required information from there. We don't take that information at all, and we will completely use anonymous information, like in our case, just the cough itself, and provide the output again back into the system where it gets integrated, it gets stored. So our job is to really get use the ABA ID, get the information, and do whatever you need to do, and again give it back to the system. So it has. So that's what we definitely want. That's one of the recommendation what I actually propose. And the second thing is earlier what Raghu mentioned, the validation framework. I mean, this is really very, very frustrating for us. Basically, whenever we go to, any of these people, somebody said, did you do validation in the, primary setting? Did you do validation in the community setting? Did you do validation in the tertiary care setting? You have done validation in South India, but you have not done in Delhi. So will it work in Delhi? It's like there's no end to this. This keeps on going. Forget about outside India. I mean, that's a different ballgame altogether. But within India itself, we have this. So how do we define that uniform validation framework? I mean, that's a very challenging problem. I don't even know, how can we think about a solution for that? But definitely some kind, I mean, see, as an entrepreneur, with minimal investment, if I can completely do one validation at one particular place, covering all the scenarios, all the environments, I should be given flexibility to get that deployed everywhere. I mean, basically, you cannot repeat this because these are very costly. I mean, costly in terms of money, time, and many other aspects of it. So the validation, uniform validation framework, and the integration of leveraging the ABDM or the ABA, make sure everybody is really using, is really what my two recommendations are.
Thank you. Mr. Chandrasekhar.
I think more or less both Raghu and Narendra had covered. So I think bringing a fundamental standardization, I think ABA is an amazing thing, even though, ABDM, integrating to ABDM has been quite strenuous, but now I think it's getting more and more stable. I think that could be, so that, like, I think few things, like making it a little simple. One is, have one standardization of how it should integrate. I'm saying standardization. ABA could be the easiest thing because that's a government initiative. The second one is obviously trying to address a problem like his. So even in private sector, if they give, like, for example, government has, let's say, a list of hospitals in private whom they consider when you're doing clinical trial or ethical committee clearance. There are a bunch of hospitals which are outside the government. So even if they provide that and say, okay, if you're doing validation, do these criteria, at least they will be able to navigate in the private sector far more easier. Okay, it could be free, it could be paid. At least that investment a startup or anybody can do. But if that directive is given, and because government, as sir was rightly saying, that government can give a grant but can't give a purchase order, right? In terms of so I think if they give these basic criteria, navigating that is always easier. Because see, a lot of times new entrepreneurs always come and ask when they want to get into government. I would always say go to government only after 7 years or 8 years of your stabilized business, because you can't handle too many things. You can't handle government, you can't handle product, you can't handle development, you can't handle regulatory. So you get that worked in private sector, and somebody in the private sector is willing to put 2 lakhs, 5 lakhs, 10 lakhs, then it must be really worth it. Use that as a starting point. And then it should not be like, again, there can be, people can misuse it, like go and get a dummy purchase order from a hospital which doesn't exist, or letterhead hospital. So I think that's why if you empanel, let's say, private renowned hospitals who will genuinely do things and get a starting point with that, and then use that as, as a criteria which will allow you to get into the government, could be very, very useful.
Yeah, thank you. Mr. Ankit.
I want to give a, very actionable and concrete, recommendation. Say, there are 32 disease areas or like sort of recommendations that have come out. We can pick any one of those. I know most about TB, but say for example, if it is for TB, the next time when we, and like sort of states have their own way of looking healthcare, every state has a different way of looking at healthcare, but they also look to center for guidelines. So the next time, say for example, when we are deciding the National Health Mission budgets, can we have a line item where we say that 0.001% of the budget given to you for TB can be used for AI? Not saying chest X-ray AI, not saying cuff AI, not saying use ABC company or like sort of XYZ company, but like we say, you can use this budget for buying syringes or X-ray machines. You can also use a small part of this budget for procuring AI. And that itself will like sort of make like a lot of health departments feel like, okay, there is encouragement and we can like sort of go broader if we want to on our own, right? So yeah, that would be my recommendation.
Thank you. So the audience has listened to us for quite some time. If you permit, we have a couple of 10 minutes more. So we can ask if anybody in the audience has any questions. We can maybe take 2 or 3 questions. Yes, please. Can somebody give him the mic? And please introduce yourself quickly. Ask the question and also to the person to whom you're asking it.
Yeah, Niranjan Shetty from Sri Krishna Sevashrama Trust Hospital. Here, validation in AI in human parts, because each and every human part is, each and every person is different. In engineering parts, okay, you can validate, but how you can validate AI in human parts?
Who are this question to?
IASC.
IASC, okay.
Frankly, I didn't fully understand the question. How do we validate this?
How do you validate AI for different parts or different human beings when each human being is different? I think that's what...
See, I mean, you can say the same thing about, let's say, some biochemistry-based solution too, right? Use some statistical approaches, data science, data-driven approaches to validate on a large enough set where you say this is now generalizable, right? So I don't think those principles really differ that much. Of course, we have a particular challenge with understanding exactly where sometimes AI fails without us understanding why it failed. A lot of that will come down to having, in some sense, broad enough or comprehensive enough data for you to understand really where it is failing, where it is likely to fail, where it is likely to work, and why is it failing or why is it working.
Thank you. Yes, please.
Dr. Bala Shetty, I'm a professor of radiology, part of Isha Diagnostics here, who give a lot of healthcare services to Indian Institute of Science faculty members also. What I would like to say is, right now he has told properly that if there are so many problems in getting these, whatever we have devised, getting into market as a utilization, as a purchase model, that is a very important point, from pilot project to purchase project. I feel private diagnostic centers are open for that, and we can take up any project because we do almost like 10,000 images per month, including CT scan and MRI. That is a data we have, but we would like to get this data converted into a purchase module. For that, we are open for that, and we would like to ask any one of you: is it so difficult to get into private centers to create this project? That's what is my question. Anybody can answer that.
Hi. So even though, like, I mean, our company analyzes radiology images to find signs of certain diseases, we don't see ourselves as a chest X-ray AI company. We see ourselves as a TB AI company or a lung cancer AI company. So we want to like sort of preempt signs of, say, lung cancer and tuberculosis. And that is where it's not like, I mean, we haven't tried in private healthcare. Like, just in Bangalore, like Aarti Scans uses our chest X-ray AI almost on a daily basis. And they have a very beautiful use case. They say that our doctors will read the abnormal chest X-rays. Can you just call out which ones are normal? So 60% of their X-rays are normal, which are being read by AI, and then some radiologist is like sort of signing over it. So that is there. But I think if you have to crack that private market, I will have to go to, like, what one state can do for tuberculosis will require for me to strike deals with up 50 or 100 like sort of diagnostic AI companies. And we are like, it's not like we have given up on private healthcare. AIMS Delhi uses our chest X-ray AI like so almost on a daily basis to just segregate cases which are the more urgent ones, which are the not so urgent ones. So it's happening in parallel. But I think the real scale can like sort of come from like sort of both private as well as public partners.
Thank you. We can have one last question, the lady sitting at the back.
Hello, I'm Dr. Rashmi from, I'm a consultant physician from HFW. So my question is, see, I know that nowadays everything is based on AI, but the thing is when you are preparing AI model, you have to have different module for private sector and government sector. Because what problem we are facing, it is totally different. So you are having one model, because I'm using your query for X-ray. Okay, I know what problem I'm facing. But when it comes in toto, so when you're preparing in toto for everyone, you cannot address our problem. And OPD will be quite a large quantity in government sector. But compared to private, it could be less. We may be seeing 10 times higher than the private sector. Okay, my OPD is more than 250 per day. Okay, it could be less in the private sectors. And what about the work? Like we don't have like a resource, human resource also much. So because the discussion was implementing into the government sector, please keep all these things in mind and implement. Because already we are overburdened. We are like overburdened with all the other things. So please make a simpler app. We don't want any complicated one. Yes, it comes. Okay, when I click on the X-ray, again I should not click on query to read the abnormalities. I know, because I'm a consultant, I can identify what is wrong, what is not wrong. So at my level, only thing is in my busy OPD, something should be striking. When I see the X-ray immediately, something should be striking, which I may ignore in busy OPDs, okay? But not like a regular one, that I can read. The thing is, I want it to be a very simpler one so that my time consumption will be minimized. It should be aiding me. It's not burdening me. Because hardly I've got 2.5 minutes per patient. One more thing, we have got a lot of burdens. See, half an hour fever, they'll come back to specialist. Because it's a government hospital. Why can't you see?
Yeah.
We are speaking about abroad and all. That scenario is totally different. No one speaks about that. What about the workmanship in our country? What about abroad? If you see more than 20 people, no, they'll say no, there is no appointment. But I can't say that.
Yeah, so I think I'll take that as a suggestion.
Yes,
that whatever
please.
solutions we build, they are embedded into the workflows and they don't add to the cognitive burden of what the doctors and the clinical workforce is already doing.
It's a very valuable point that she makes, that, it's an issue of design. And I think one of the real constraints to adoption of technology is existing workload shouldn't increase. And I think it's a valid point. You have to demonstrate that actually work becomes simpler or they are able to become more productive. I think it's, in terms of designing something, it's a very, very valid.
Thank you so much. I mean, we can have these questions. The speakers are going to be here. You can ask them individually. In the interest of time, we will close. Any closing remarks from the chair?
I think I really have no specific closing remarks except saying that there are very valuable insights and very practical insights which we need to look at. There is this issue of how government procurement comes up. There's an issue of standardization and having certain standard protocols which can be followed. There's this issue of making sure that it works in all scenarios. I think when he started with even the basic infrastructure being in place if you're going to scale up. And I mean, all of those need to be addressed, and the challenges are many. And see, one of the things is, and I think one of the ways in which the job market also in a sense gets saved is because the adoption of AI is not as rapid as the technology companies initially threaten or promise. And it sort of, the diffusion takes place a little more slowly because there is a resistance, various kinds of human resistance. And I think a very valid point which is made on, and which is very similar to what the doctor also said, that solving the behavioral element is the most critical element. And I think that is something we have to work towards. So very practical insights, and which I think both India AI Mission and NHA needs to keep in mind as we sort of evolve this. Thank you.
Thank you so much, sir. And I thank Krishnan sir and all the panel members for sparing time and giving your valuable insights on this very, very important topic of building AI for healthcare in India.
Thank you, sir. Thank you, sir. Thank you for our district. May I now request Mr. Kiran Gopal Vaska to kindly present token of appreciation to the chair and all the panelists. First, Shri Krishnan, Secretary, Ministry of Electronics and Information Technology, Government of India. Second, Mr. Ankit Modi, Chief Strategy and Growth Officer at Cure AI. Mr. Chandrasekhar K, Founder and CEO of Forus Health. Mr. Narayana Rao Shripati, Founder Director Swasta. Mr. Raghu Dhanraju, CEO of FR. May I now request everyone to take their seats in the audience.
To one of the most anticipated segments of the AB PMJAY Auto-Adjudication Hackathon 2026, which is the showcase of our shortlisted winner teams. Over the past few months, more than 3,500 participants from across industry, startups, and research institutions engaged with the hackathon across 3 problem statements focused on the strengthening the claims adjudication ecosystem under PMJAY. Following multiple stages of technical screening and evaluation, the top teams are here with us today to present their solutions. These solutions have been reviewed by distinguished evaluation committee members comprising experts from the leading institutions, government bodies, and the AI and healthcare ecosystem. Each team will have 10 to 12 minutes for the presentation, during which they are expected to broadly cover the approach adopted, key technical aspects of the solution, and its scalability for wider implementation. Moving on to the first problem statement, which was clinical document classification and compliance to STG requirement, which focused on developing solutions capable of automatically processing claim documents along with the standard treatment guidelines issued by the National Health Authority and validating whether the submitted claim documents comply with the prescribed STG document. May I now invite the winner under problem statement 1, Mr. Vinay Babu Ulli from Team Nirnaya, to take the stage for the presentation, please.
Hi everyone. My name is Vinay, working as a lead ML engineer in a startup located in Bangalore. I participated in problem statement 1. So I have 8 years of experience, 4 years into ML. From last 1 year, I'm working on working related to NLP for healthcare. So I have few publications around how I have fine-tuned small language models for clinical document summarization, question answering around healthcare. So I'll explain about the problem statement. So first, we got a claim or case where you have a set of documents. The document can be in PDF or image, and it goes through our solution. We have to come up with a solution where we also have to consider the standard treatment guidelines, and finally we have to come up with a structured schema where we have values extracted from the documents. So these, for example, so these are different packages we are given, and these are the number of keys to extract, the key values we have to extract. So if you take this one, so you can see we have around 16 keys and then the corresponding values. So if you summarize, if you group it, so we have a document level keys. For example, what is a case ID, what is the package it belongs to, the case or claim, and what is the page number. So these are like deterministic, like you can simply get it. And then there are some key documents, whether they are present or not, we have to find it. And also there are some clinical classifications we have to do. And we have to find whether it is an extra document or what is a document rank. So these are 3 different categories which we can think. So yeah. So it looks simple, but it's not. It is not, because these documents, as I said, it contains PDF and images. These documents will be in multilingual, so it can be in English, Hindi, or any other regional languages. So sometimes your document, let's say if you take a discharge summary, it can present in multiple documents, like page 1, page 2. Page 1 can be one document, page 2 can be another document. So sometimes in one document you can have multiple reports. So we have to extract this schema, this set of parameters for each and every page. So that is the problem statement. And if you see, this is how the document looks like. That's why this problem is a bit hard. So the problem, sorry. And this is the data set we got. For example, if you take severe anemia, we were given 10 claims. So you will get average 35 pages per claim. And there are some claims where you have 99 pages. So we have to run this analysis for each and every page. So this is the approach I followed. Stage 1, where we extract these key parameters, not all the parameters, a few parameters. And in stage 2, we do post-processing, and we use the extracted parameters from the first stage to come up with some parameters in the second stage. So in the first stage, first step, what we have done is we have taken a document page, and I have used a Gemma model, which is a multi-model, which means it can understand text, it can understand image. So from that, I was able to get the OCR text, the text which is present in the document. And also, there are scenarios where we will get the images, scans. So for that also, I've got an image description, like what is it. So I tried different approaches. I tried using test-rack, but because of the complexity of the text which is in the document, so somehow the model, this multi-model Gemma 3 gave a better output. And it uses a similar vision encoder of Gemma 12B model, so I've used this one. In the second stage, in the first stage, once you get the extracted text and your image description, we pass this package schema details with STG definitions, like what is for every parameters there is a definition. So those things to a prompt, prompt construction step, where a prompt will be constructed and it will be passed to a model called Gematry 12B instruct model. So it has 12 billion parameters. And from then, so after that, we get the package-specific schema output. We'll not get the document rank, we'll not get the extra rank. So I thought we'll calculate using in a deterministic way, not to go with the LLM. So why I have used Gematry 12B instruct model? So this works very good for Indic languages. So we were given an option of 5 language models. So out of 5, so this has a good performance on Indic benchmarks. So I've gone with this. So this is a prompt which I'm using. So if you see this looks like a code. So here we are giving a package, whatever the text which we extracted in from the document, also whatever the image description we got it. So so package-wise, so once we give the package-wise, we have a list of keys, right? So we have to come up with a description for key. For example, clinical notes. So by looking at the standard treatment guidelines, so I was able to come up with a description about what this key indicates. Okay, so we'll set this clinical notes to 1 if this page is a clinical note with detailed history. So this I got it through the standard treatment guidelines. And if you want to increase the accuracy, we may need to tune this. We need to put our domain expertise, and we have to come up with a proper description. The same thing I followed for other packages, and I was finally able to get these parameters. So one thing I understood is, so as I said, you have a document, required documents. There are some set of keys where we need a required documents, and there are some keys where you need a clinical assessment, like presence of anemia, right? So these, if you take a page in a document, it cannot have multiple reports. So in the prompt, I mentioned that document type flags are mutually exclusive. So if it contains discharge summary in a particular page, it cannot have another reports or something like that. But your clinical fields are independent. So one particular page can have multiple clinical fields. So this is how I've constructed the prompt. Also, I've mentioned it to use a strict JSON so that at the end it needs to output a JSON. So that was in the stage 1. So in stage 2, once we get the key and value pairs from the LLM, so we have done a date normalization. So all dates to a particular format. And I've done a within file grouping. For example, if you take a PDF, it can have like 10, 15 images, right? So I've done a grouping, like let's say the discharge summary can have multiple pages, right? So I've done the within file grouping. And sometimes you can have multiple images for a same report. So I've done a cross-file group merge. So this is done based on the presence of those key values. And then we have done a file level extra classification. So if you see most of the schemas, as per the standard treatment guidelines, so they definitely look for presence of required documents. So if the presence of required document is not there, like let's say the values for so if the values for this presence of clinical notes is 0, which means it's not there. If the CBC HB report is not there, then the same way if the other required documents are not present in that particular document or page, we will label it as a extra document. So you don't need to use LLM or AI to come up with that particular parameter. So you can relate some keys to the other keys. So this is how I've done the extra document classification. And for document ranking, I've simply used a lookup table. For example, within a page, if clinical notes is present, so I'll assign a document rank as 1. The same way for other packages, by looking at the presence of those required documents, I came up with this ranks for the document. So So this is a solution I was able to develop. And coming to the tech stack, we have used Gemma 3 4 billion and 12 billion model via NHAI client. And I've used PyMu PDF for converting PDF into images. I've used Pillow, Pandas, NumPy libraries. And I've used DSPy style, this prompting techniques. The scalability, if you come to the scalability, each package is, each page is processed on its own. So it's not dependent on the previous page or something. So you can run these analysis parallelly across pages and across the documents. So if you want to add a new package, it is easy because you just need to define what are the keys present and then their corresponding description, and you have to come up with the ranking, like what is the set of ranking we have to follow. So these rules can be configured in a simple config file and can be given to our prompt for the prompt construction. So this is a simple prompt construction which will go through the large language model and gets you the required structured output. Yeah, so we can further improve this by fine-tuning, by having a better model for OCR. Yeah, so that's it. Thank you very much.
Thank you. It was nice. There's just one question. You said that in one of your slides, you said that you have marked the document type as like standalone. So it's like if it is a clinical note, it is going to be clinical note. If it is a discharge summary, it's going to be discharge summary. But what we have seen in real claims is what happened, that let's say I talk about the dialysis claim. So we also trained our model like similar to what you have done is. So what we saw is कि एक discharge summary में ही उसका clinical note भी था. So there was no separate clinical note and discharge summary because in there are so many hospitals across India, so not everybody follow a similar pattern or like a medical pattern or SOP. So this is what we have seen. So will it work in that case where this happens?
Yes, I think like one thing is definitely we can tune the prompt to have those rules. Like, okay, the document can contain multiple documents. Image can contain multiple documents, or can contain like some relations. Okay, a document can contain 2 or 3 documents of specific type. So these rules can be embedded within the prompt and can be used. But definitely I mean, like not just by going through the prompt, we can also, so here we used something called zero-shot prompt. So no examples. So you can have a few shot prompting where you provide some examples and what are the expected key value pair combinations. So by having a few shot prompting, or if you can also do a fine tuning to improve the accuracy and all. Yeah, those things can be done. So, but here I went through that assumption of that only one page can contain one particular report, but we can further modify, fine tune it. Thank you.
Okay, so have you encountered those stages where more than one classification was given for a single page? So can you show me like the prompt? Can you go back to the prompt? Yeah. Yeah. So where are you handling this single thing?
Yeah, so
it
here
should not overlap.
You can see document type flags are mutually exclusive, right? So that is where we'll get the document related key IDs.
So you are iterating this one by one sequentially, right?
No, the one page will be run
across.
No, one page will be run. Then I'm going for the next page. But this can be parallelized. We can do it parallel. Right now, I don't know whether the batching will be supported through API, but can be done through batching. For example, like if I'm using a Gemma 4 billion model, so if you have a GPU of 40 GB, so then if you are sending one request, so at max it can consume 15 GB of GPU. But by adding more batches to it, like for example in our case, by adding more pages to it, things can be done in parallel.
So let's say in one shot you find out clinical node.
Correct.
Okay. Then you will not search for the clinical node again, is it?
Yeah. So that
Yes.
is what. No. It's like every page will go through the same process. So it's not like okay, page one we found clinical node. So that information we are not giving as a input to the prompt for processing the next page. So that is again sequential. Can take more time, but I don't feel like that is not required at this time, but can be handled in the post processing.
Okay, so that's what my question was. So let's say in first go you said that page number 20 is clinical note. Then page number 22nd is also clinical note.
Okay.
Then how you are figuring out which page number is which one?
So in that case, since it's done at the page level, so I'm going with the same for the whatever is given by the LLM. But as I said, like there are scenarios. So we do cross-file merging and within file grouping. So in that case, if document page number 20 is clinical notes and if the page number 21 is clinical notes, then we group it as a clinical note. But if there is a gap in between, so that those are the edge cases we didn't handle.
Okay. Okay. Thank you.
Sir, maybe in this data you didn't encounter such an example that if there is a document which can be classified into both the streams, then what does the model do? Does it discard it or?
It discards. So it
Then
doesn't
it discards
consider. It discards. It takes whichever is more relevant. It assigns that particular tag. So it doesn't consider, okay, this contains both clinical notes and some discharge summary. So it will not label it as one for both. At max, it just considers only one as a.
So
one
how does that is being decided? Like
so
which
that
one
is
to choose?
decided through the prompt. So if you see document type flags, so we have a set of flags for the document types, right? So for every package, these are the requirement documents. For every document, we have a key is there, right? So those should be like
so more
mutually
flags,
exclusive. So
more
it should be
flags
only
is
one.
matching. So supposedly there is a document which matches some flags of some and some flags of some. So the more flags which are matched, it will be classified in that category.
Yeah.
What I'm able to understand. Yeah.
Thank you. Any other questions?
Thank you, Mr. Vinay. Next, may I please invite the runner-up under problem statement 1, Ms. Khushi Singh, a final year student from IIIT Gwalior, to take the stage, please.
So, very good afternoon to all the esteemed dignitaries and everyone present here. I am Khushi Singh, a student pursuing BTech in Computer Science from IIIT Gwalior. So, our problem statement was PS1, which is document classification and STG compliance. So, first, I'll move on to our understanding of the problem statement. So, for the problem statement, auto-adjudication refers to the process of making the claims free from human intervention. So, Like if we submit a claim, we have to verify it as a successful claim, a failed claim, or a conditional claim based on the relevant documents and everything. And we have to produce a explainable decision under the 3 categories. So we divided our problem statement into 3 stages. The first was the multimodal extraction stage, where we extracted key medical terminologies using our VLM and the visual proofs like stamps, signatures, barcodes, etc. The second stage was timeline and checking against the STG rules. The timeline construction involves the episode timeline construction, like pre-authorization process, and then the process when the patient is admitted, and then the post-authorization process. So the documents will be like fit in a timeline accordingly. And then we'll verify it according to the standard treatment guidelines and see if it matches and produce a confidence score. And then the last part was the explainable decisioning, where we had to like specify the category based on the confidence score, whether it is a successful claim or not. So the key things that we noticed while working with the data set included, the first thing was there were a variety of claims, including high quality and low quality documents. So for handling the low quality documents, we passed on a flag. So if so we had a threshold basically. So if a document is like a very low quality document, so we passed a flag claiming that it is a low quality document so that the VLM can handle it accordingly. And it won't pay much attention to it because it's very blur, and it will just try to extract whatever information it can get. The second thing was handling the multimodal data. So for that, we fine-tuned our Gemma 12b to like, in the context only, we mentioned that we are dealing with the multilingual documents. Then we had dates hallucination. So the VLM was hallucinating with the dates. So we followed a proper format for all the dates across all the documents. So if we talk about the problem statement flow, the first part was to ingest all the documents, and then we extracted the key text fields and visual proofs. And then we constructed the timeline, and we checked it against the standard treatment guidelines and produced an output decision. So this is our system architecture. So as you can see, the data set was like divided into 4 cases. So that was stored in the case folder. So we ingested the data set accordingly. Like there were 4 cases, and each case had like the data for each patient accordingly. And under each patient, we had multiple documents as well. So the first thing that we did was to label using the ingestion, like which particular disease is being talked about out of the 4 cases. The second thing we used was the tag data was then fed to a page normalizer. The page normalizer was used here to like increase scalability, because we wanted to like reduce the size of the image so that the token usage can be reduced. The next step is now after resizing the image, we fed it into the primary Gemma 312b model. So we had like 2 stages of the Gemma 12b call. So for the first call, there were 2 things. The first thing was quality flagging. As I said, if it is a high quality document, the model will focus more on extracting the fields. But if it is a blurry document, so it won't spend like much tokens extracting the things from it, and it will only like the relevant insights it will try to take. So first was quality flagging, which was used for this. And the second thing was visual detection for like taking out important insights in the form of stamps, barcodes, dates, and medical terminologies. The secondary Gemma call was made for per PGF, for per page analysis in the PDFs. And if it's an image, so we'll comply with 1 call only. The next thing that we curated was a keyword layer, which was totally from the standard treatment guidelines. So from the standard treatment guidelines, we prepared like a vocabulary of keywords so that we can map the output from the VLM to the keywords in the vocabulary, and we can then check it against the standard treatment guidelines. Also, the keyword layer contained like various forms of words, like the similar term can be like it can be shown into different things like HB, capital, small, everything. So that was handled in the keyword. The intersection is the similar thing, like we performed a fusion between the output of the gamma call and the keyword layer so that we can feed it into the STGs. And the standard treatment guidelines were used to create a rules engine based on if-else statements, like what all relevant documents are present, so that we can check against it and produce a score based on the relevant documents and medical terminologies present. And according to the confidence score, we classified it as pass, conditional, or fail. So what we noticed was, my team noticed that we cannot like handle the case only with pure VLM. So we applied a hybrid approach for VLM plus keyword approach so that we can perform a more explainable decision making. So this is our methodology. As you can see, the first stage is to ingest the documents and to normalize, resizing and everything. The second is the gamma call, where we have our VLM, which will extract everything and produce a JSON. And the first gamma call produces a cache, so like when we rerun, the cache is passed on. And then we have the secondary gamma call for the individual pages. Then we had our keyword layer, which extracted the keyword so that we can compare against the temperatures and everything. And we also converted our temperatures because we faced difficulty there into Celsius and Fahrenheit. So we had to standardize it there. And then we have the fusion layer to like compare the keywords and the STGs. And then we had the post-processing stage where we produced our final output. So the major part of our solution was the standard treatment guidelines engine. So this contained like 3 things: the package and the mandatory documents according to the package, which were taken from the STG documents provided by the team in the data set. And the third thing was the clinical issues, like if there is a certain temperature defined or the medical terminologies that were defined, like the temperature should be greater than this to assign it a successful claim, or so that was handled by the third stage. So coming forward to our tech stack, we used Gemma 312B via NHA client, which was provided on the platform itself. Then we used PyMu PDF to process the PDFs as individual images. Then we used libraries, and then Pydantic for handling the JSON. The challenges we faced included, first was blurry and low light scans, which was tackled by the threshold and flagging. And then the second thing was multilingual content, which was curated specifically in the prompt so that it can handle multilingual content. The third thing was that we had a high token usage. For high token usage, we used 2 things. The first thing was we cached the outputs across runs, and the second thing was image resizing. And so for scalability considerations, we have like future editions here. Like for future editions which are not incorporated in the solution, we consider using open source knowledge graphs so that there can be a more explainable decision making through graphs and nodes. And second, we plan to use some small language models in the pipeline wherever we can to reduce the token usage. As such, when we are flagging it, so there small language model can be used. This is my team. And I would like to say that this problem statement was not just a hackathon problem statement for me. This is something that I've experienced myself. So I had struggled with tuberculosis for like 2 years. So I was surrounded by medical jargons and everything. So like when this problem statement came out by the NHA team, it felt like really relatable. And so I tried to work on this. This is my solution. Thank you. Sorry, Mom, I cannot hear.
That doesn't require investigation. It is only clinical examination.
Okay.
Okay. Is there anything that can, that type of disease we can climb? Because many alcoholic patients they will come back with the peripheral neuropathy. Okay, diabetic patient will come back with the peripheral neuropathy. So we have to give them B12 injections.
Okay.
How do we claim for them?
Ma'am, can you please repeat your full question because you're not audible earlier?
My question is, can we climb without investigations? Because investigations are mandatory, right?
Yes.
Can we disease which doesn't require investigation, only clinical examination and clinical notes?
Yes, ma'am. We can curate a specific standard treatment guidelines for that. The standard treatment guidelines contain it according to a particular disease. So when we were dealing with it, it contained that it should be there, that there is a clinical note. So we dealt with it accordingly. But if you're telling that there is a disease where a clinical examination and other documents can suffice, so for that case, we have to curate a specific standard treatment guideline and we can incorporate
Many
it.
times, simple secondary cases are rejected because of that.
I will add on to this. I am looking after the health benefit packages at NHA. See, I know Karnataka is using its own TMS, but the whole basis of this auto-adjudication solutions which they are making is that there is a package and there is a treatment guideline, right? There is a standard treatment guideline. They have coded according to that treatment guideline only. So for every package, we have the symptoms mentioned, clinical examination findings mentioned, the investigations mentioned, and treatment which needs to be given, which are mentioned. So they are basically automating it in a manner that all these things are complied with. So I think SAST needs to do similar thing for that. You are not following our treatment guidelines, I believe, because it is using 1.0, HBP 1.0 even now. That is what she is a technical person, but she replied it accurately. There has to be a standard treatment guidelines to make the solution work or to curate the solution accordingly.
Thank you, sir.
Thank you, Khushi. This side. So, one question. You said that you have applied Gamma 3 twice. So one was first call was given for one call, for one task, and then you gave the second task when STG was validated.
Yes, ma'am.
So how you think this has optimized on your cost? Because you did it to optimize the cost. So just want to know, without this, what was the cost per page? And with this, what is the cost per page?
So, ma'am, this was for the token usage reduction. So, when we had documents for a particular patient, so we had individual images and PDFs. So, if I have an individual image, so I made just a primary call. But if I had a PDF of the corresponding images, so it contained 12 pages or 13 pages, let's say. So for that, what I wanted to do was I had to carry the context from a single page to the whole document, and then I had to analyze the separate images also. And if I applied it, like for the 2 calls, if I applied it on the images as well, on the individual images, like no PDF, so it would consume more tokens. So for like single images, we used only 1 call, and for PDFs, we used twice.
Hey Kushi, see, we are trying to adjudicate using technology. Yes. It can happen other way around, right? Like people are using AI-generated documentation.
Yes.
So how do you handle that?
So for that, we need to incorporate anomaly detection techniques. Like we need to first have an anomaly pipeline where we can exactly encounter if the document is a real clinical document or it is an AI generated document. So for that, there can be like, there are technologies to detect deepfake and everything in images right now. So in the current scenario, if there are AI generated clinical documents claiming for false claims, so in that case, we can first use a full pipeline to exactly detect if the clinical data is a real clinical document or it is an AI generated document. So for that, we have to incorporate a full pipeline in the solution.
Yeah, thank you.
So, good afternoon, everyone. So, I'm Dr. Roma from Dr. B.R. Ambedkar Medical College and Hospital. We could actually understand to some extent, but for better understanding, I think if you could have added a form, a claim form which has been already pre-filled and show to us, I think it would make better impact in our understanding.
Ma'am, I would take that suggestion, and if you want, I'll prepare a slide accordingly.
Yeah.
I was preparing the slide to give the basic idea, so I didn't actually include that example. But if you want, I'll do that.
Thank you.
Yeah, just to add 2 points to what they both told.
Yes, sir.
We are going to use multiple layers of AI API calls for
Yes.
this thing. I'm a clinician.
Yes.
And I work in Tanu.
Yes.
Is delivering AI solutions.
Yes.
So, clinical auto-adjudication can add a layer where you can have other multimodal data with which you can adjudicate whether there is a true or a false coming from an ophthalmic perspective.
Yes.
If there is a cataract adjudication document,
Okay.
you can have a photo.
Yes.
With the red, the red eye reduction. If it is off, you can see the cataract blocks the light in that eye.
Yes.
Before and after surgery. So, including API calls also makes the model very heavy.
Yes.
And probably more expensive for utilization in government setting.
Yes.
That is one. Second, pre-filled forms, ideally on such fora are better not to show. You can use pro formas which you could use. So better not to use patient data even if you have anonymized it enough.
Yes, like the data set we had was completely anonymized by the team itself. Like it had been,
I understand.
yes.
The thing is to the doctors.
Okay.
Because we are regularly handling patient data, we
Yes.
forward our reports for second opinion on WhatsApp.
Hmm.
Ideally, that is not legal.
Yes.
Yeah.
Thank you. Thank you, everyone.
Thank you so much, Khushi. Now, may I please invite the second runner-up under problem statement 1, Mr. Vijay Balaji and team from Vidal Health for the presentation.
see here as well.
Sure.
All the best.
Ready? Hello, everyone. Good afternoon. To begin with, I would like to quickly thank NHA for conducting this hackathon and giving us an opportunity to gather today. And to move on, I'd like to quickly just introduce my team. So my name is Dr. Mukul Jain, and I'm a Principal Data Science Manager in Vidal Health. And with me, I've got Ayush Derashri, Kartikeya Bhatnagar, and I've got Vijay Balaji, Satvik Pathak, and Abhishek Sinha. So they are all part of my team, and we are working on creating a similar kind of solution which actually solves auto-adjudication of health insurance claims. And in Vidal, I'll just maybe take 1 more minute and quickly talk about what we are doing in Vidal. So we have created a platform which does most of the things that we are going to be talking about in this 3 tracks of hackathon. Most of these things are actually being done in a single system through document categorization and applying all the STG rules and detecting fraud and categorizing all the information and making it easier for doctors to process claims faster, right? So that is what essentially we try to do. And moving on, let's just quickly understand what the problem statement is. And since the previous 2 teams have already covered some bit of it, we'll maybe skim through some of the quick insights that we have understood in last few years of our experience, right? So usually we get less than 15-20 minutes to look at all the documents that we have received in a claim and take decisions, right? And on an average, there are 30 to 40 pages that are available in claim documents. And it is practically impossible for a person to minutely observe 30 pages in under 20 minutes, right? And again, on top of that, there are a lot of complexities of packages and a lot of rules, a lot of variety of claims and so on. So it makes it so much more complex for a doctor to, or a claim processing doctor to understand all these things in a matter of 10-15 minutes and take decisions, right? So it is very important for us to leverage the power of cutting edge technologies like AI and all these machine learning techniques to see what we can do to make a doctor's life easier and simpler. And given the audience today attending this session, we have actually kept the session a little more logical and less technical, so that all the senior doctors who are attending the session, they can probably relate to it and they can also maybe contribute to the solution, right? So what we have discovered while talking to doctors is most of the time they are trying to interpret the documents which are not really complete. So they keep identifying documents which are missing so that they can go back to the patient and ask for more information. They have to actually keep balancing between trust and suspicion, because they want to believe that whatever documents they have received are actually genuine, but most often there are a lot of different elements of fraud and abuse in those documents. And the expectation here is, since we are getting almost 50,000 claims a day, they have to rapidly process claims so that they can move on to the next one and immediately attend to the next, let's say, patient waiting in the hospital for pre-auth or discharge. And eventually, if you look at the complexity, no 2 hospitals or doctors or claims or treatments are similar. Although they look very similar, but they all come with their own unique nuances and different complexities. So it is a little difficult for us to generalize the entire solution to solve different kind of medical complexities. Now, how we have actually broken down this problem, there are multiple different stages that we have actually jotted down. We'll talk about each of them in detail in the subsequent slides. So I'll now invite Kartikeya from my team. He'll take over. Thank you.
Thanks, Mukul. And as he rightly said, what we tried to solve for this problem statement was to replicate a human agent or an adjudicator daily life process. And to do that, the major challenge and that we encountered, how will you introduce reasoning and thinking into an LLM model? How an agent currently, when he sees a discharge card, he knows for discharge card you have to extract DOD. For clinical documents, you extract the clinical fever details or etc. Right? How will you, without hard coding, without keeping the code static, will introduce all these things into your system? Then we came up with our solution, which was built on agentic React, which means reason and action system. So we divided our whole solution into multiple sections. As you can see in that architecture there, our process starts with the brain, the agent executor chain that decides what is the procedure for this claim that is received, apart from this procedure, it also loads the STG document. So STG document has been a major part of this problem statement, and according to that only we have to take a clinical decision over this case. So we ground our LLM, we ground to reduce the hallucinations, to increase the output accuracy. In the initial stage only, we ground the LLM with the STG output. So we built a custom RAG model over it. We page index the STG documents, and we integrated that with the agent brain. Now the brain has got the STG document, it knows the procedure. In the second step, it identifies the package and loads the STG document for it. The next step for any agent, which would be to see the document page-wise. We also extract from the PDF, separate the pages, extract each page, and then process them accordingly. Now in the processing step, there are multiple different things that we are currently tackling and doing. First is the OCR. We extract the raw text from the document, and with this we also categorize the document. So in a single LLM call with this tool of OCR, we extract the text and also categorize that. Up next comes NER, the identification of clinical identifications from clinical documents or blood reports, or for example a post-op X-ray. We need to identify in a post-op X-ray if the implant is used or not. If we had implemented a static workflow, a static tool, it would check this on mostly all of the pages. But with our agentic workflow, the agent decides if this is post-op X-ray, is this a case of is this a case where in STG it is required as a mandatory document, then it only checks that and moves forward. The next step was to validate all the visual cues, the page quality detection, the document categorization. These are done by keeping these tools statically and orchestrating all of them by an agent who thinks and responds basis on the output it has received from its previous flow. Coming up next, we had STG-based clinical identification. Now, this in a single LLM call could be much more hallucinating, could be much more not able to extract every single detail from every document. So for this hackathon, we had already received a set of output, a set of keys that we need to extract for each of the procedure codes. Hence, we had a separate tool that called all those for those pages, like for clinical document, for enteric fever. We needed to extract the fever, the symptoms from that. Based on the keywords, based on the keyword detection, as well as supported NER LLM call as well. So these steps defined an end-to-end agent processing life with thinking and reasoning into our system. Coming on to the technology stack that we used to orchestrate all these was simple Python. Apart from that, we used LangChain framework, that was React, to bind this and introduce the agentic workflow. For this, we used two majorly. One is chat completion model, that was Nemotron 30B provided by NHA, and the another was to the Vision LLM that we switched from Gamma 3 billion and 4 billion parameters. So all these things can also be later scaled up to multiple models, to multiple different illnesses, not restricted to these 4 illnesses. Now, if you can imagine, think of a scenario that tomorrow we need to tackle a new illness. For any system, we will have to study the document, study the STG, create a different prompt for it maybe, create a different clinical understanding that we have to give to the system. But with this flow, you just have to add few keywords, few understanding of the document, load the STG document for that, and just run it on those cases. It will tackle all the other things. Now the novelties that we have handled, these were the 4 major blocks of the complete solution. The document understanding, the documents were very messy, they were not very clear. What we did, we did 2-level OCR and understanding of the document. One was using the Vision LLM, which identified the document, and second was supporting it by key clinical keywords that we have found out based on the studying those documents. Apart from the medical, second part of medical episode handling. So in medical episode and in extraction of dates, we majorly found the major issues. The date was not extracted correctly. The date was not written in the way that can be extracted easily by any of the Vision LLMs. We found 7025 instead of 2025. So we ran another tool that was revalidation over all these scripts that actually identified the correct date based on the number of concurrency, based on the current date, based on the actual date that has been extracted from one of the documents, and revalidated all the dates across
the documents and propagated it. This was majorly a post-processing step that we followed. Apart from this, for the scalability and performance, as I told, this process can be plugged and played into any system. We can create different pipelines for it and easily integrate this. A case can come, can get processed, and just move out into a queue, like a queue-based system. Also, the tools that we have created. So these are nothing but just starting functions with some knowledge. They can be integrated to any system. So tomorrow, if someone wants to use the doc categorization model of ours, they can directly use that model, integrate into their existing system, and the accuracy, or if it is better, will jump on and move forward, or just complete system. Coming on to the KPIs and valid success, I'll let Vijay to move.
Thanks, Karthike. So all these were, technically the architecture, all these were told. Now anything has to be evaluated. So the success, how we measure, is going to be cost, time, and accuracy. So cost is, we've written the importance for each of these metrics because these have to be developed for all the applications that we're doing today for healthcare. So cost, it is important because every penny spent on the tool, calls, all these have to be monitored because ultimately it boils down to cost per claim. Now, how do we track it? We have an option there, and how to improve it is also there. Yeah, it's coming up. So the idea behind cost is at scale, when we are going to improve this, how is it going to fit in? That is about it. Now, time. Now, we can't wait for this entire process to run because someone is waiting at the pre-auth and we have to give a decision fast. So this also has to be tracked, and that is the importance. Now, how can we track it? Microservices and queue-based architecture where we can do this. The third is accuracy. There is no question on accuracy. It has to be implemented. And for that, we have multiple tools today, one such as LangFuse, which can help us to keep track of all these models and assess every decision that we take via these models. This is about how we evaluate success at scale. Now, challenges, what we wanted to highlight is threefold. STG retrieval today, when we see it's a document which is like properly written, vetted, it has some pictures from STW document, so that that document is not machine readable. It is like human compiled data on which we are running RAG. Ideally, we feel it could be in a very structured form which is machine readable so that we can move this at scale instead of guessworking or doing a lot of guardrailing. Second is mid-processing failure. So assuming this process is running and somewhere it gets stuck, the AI compute, the efforts involved, the cost involved should not go to waste. And the hackathon is about auto-adjudication, but it can also serve as a co-pilot for someone who's working on that claim. So how can we use this to ensure, for example, they are taking 10 minutes to adjudicate a cataract case. Can they do it in 5 minutes with the compute that we have given with this? So that's the second mitigation plan which we feel should be done. And third is, we should have a very robust ground truth and evaluation for all these, again, going back to the accuracy of our success plan. And integrating a real-time monitoring and tracing framework is very much essential for this. So these are the key challenges we feel, and these could be the mitigation plan that we can develop for it. Now, we have got these learnings from the hackathon, and we wanted to highlight it here. One is the claims co-pilot part, so that at least auto-adjudication can also lead to co-pilot, making a human 10x productive. Second is the policy markup language, which is also a part of NHCX protocols. If we can convert STG into a very machine-readable format of documents, scalability becomes easier. And third is, today we are assuming the transaction has come inside the system, transaction management system. But can we optimize it even before the transaction is hitting us? Can we ensure the document is complete? Can we give some nudges to the hospital? Because we do not have visibility of a patient entering a hospital. Unless and until a transaction originates, there is no time that we can actually compute today. So all these are some behavioral questions, product management questions that we need to ask, where there should be a blend of product management, consumer understanding, hospital behavior, as well as the data science plus medical evaluations that we have. So this is about it. We'll just show a small sample as to how the agent gets initiated, the thinking chain gets established, and then after all the validations happen, it finally assimilates a chain and the output comes here. Thank you.
Vidal team. The last slide where you have suggested 3 suggestions for NHA. I think the last one we are already working on, where it is like a intelligent document classification at the claim submission level. And this one also, the second one, it's a good suggestion. And the first one, we are already doing it, but though we are doing it through a human in the loop. But yes, I think you suggested a solution where there is a AI model which can use it. I think you, in the previous slide, you said that this one, this Lang Fuse is doing your ground truth and evaluation. So we'll also do that. Thank you. Thank you.
I'm Dr. Pramod, Deputy Medical Superintendent from MBJ Medical College. First of all, thank the organizers for giving us an opportunity to have an interaction with the fast-moving AI integration into the claims processing. I'm very happy regarding the presentation that you had given. One point that one of the speakers said that right from the time of entry of the patient till the time the patient leaves, unless the document reaches us, we will not be knowing what the status of the patient and the treatment protocol that has been followed. Also, I would like to ask, it's just a suggestion, can there be an interactive phase or a module wherein all that queries that you are going to raise, yes or no, can be done right in the real time by the treating doctor? Because there will be many places where the doctor himself will be uploading it, or a person who knows the patient details will be uploading it. If there are pop-ups on the screen, right away, whether it's available, not available, it can be done and dusted away within minutes. Rather than holding it on, next time the patient sees there's a new LMI, then they need more information, then you have to give it. Instead of all that, whether it's available, not available, it can be done away with it immediately. Is that interactive module or the phase possible? Point one. Second, this suggestion is to the Ayushman Bharat board itself. Because we've been seeing through the various slides and various speakers, they are developing models to determine whether various categories of information, be it the clinical notes, be it the investigating reports, be it the follow-up, whatever the follow-up reports, etc., parts are being searched, and you are developing programs for that. Instead of that, if the board itself gives all the institutions a set format, what is applicable. I know it cannot be a same format for all diseases. If it's not applicable, NA. If there are certain tests, yes, those tests are there. If those tests are not there, it applies NA. So that even for the person who uploads, it's easy, there is clarity, and there is no need of spending time, energy, money on differentiating the various things. So that it's available, not available. If not, you need more information, it immediately pops up as on an interactive module, and it gets cleared off within a small time, and there is clarity, rather than going around asking for the information which might not be reliable, and the machine will not be able to know whether it's required or not, because it's an AI one, many times human interface might not be there. Have a generalized format. If it's applicable, not applicable, or if it's applicable, then provide the data, and it gets finished off within minutes. If the board can take the suggestion and give their opinion, it will be grateful. Thank you.
Sure. Thanks, Dr. Pramod. And I'll try and answer your first question, wherein you are trying to understand if there is a real-time suggestions that we can probably give to the doctor, the claim processing doctor, wherein they can maybe identify if there are missing documents or any missing information. Is that the question?
Yes, yes.
Yeah. So I think I'll just maybe quickly give you a background. So when we began this entire development and integration of the system that we are building in-house, this is exactly how we started. But then we realized that the information that is coming to a doctor is actually coming from a hospital or maybe the end user when it is a reimbursement claim, right? So what we have done is now we have actually taken a step back, and we have integrated some of the AI capabilities in the applications which are customer facing. For example, provider portal for hospitals and employee and customer portal for reimbursement cases. And what it does is, the moment you upload a 50-pager or 100-pager document, in a matter of 7 to 10 seconds, it actually gives you a quick summary of what you uploaded in all those 100 pages and what all documents are missing. And it actually gives you a nudges that depending on what we have read from the document, what apparently could be a missing important mandatory document which could lead to a delay in the processing of claim, and we give a nudge to the customer or the end user that if you don't upload this, then it might take a little more time and you might have to upload it again later. So you might as well upload it in the first go. So that is exactly what we are doing. But maybe just to quickly answer your question, yes, we can create some interactive options for doctors, but since the documents usually come at a go, right, 50 or 100 pages actually usually come in a PDF file. They do not really upload one PDF file or one single images one by one and not over a period of time, right? They usually upload 50 pages, be it images or PDF at a go. So creating an interactive system for doctors which will probably look at every single image in real time before they finally submit a claim may not be really ideal. I hope I answered your question.
Yeah, I understand when there is a long set of documents, it takes time.
Yeah.
But once the documents are uploaded,
Right.
then getting the information also, if it's a real-time
Absolutely.
then
That happens
if there's a real-time upload of whatever the queries are, then it can be answered immediately. That's what is the question.
Right. That's how it operates today.
Thank you. And the next question, what was to the board, if we can have a generalized format that will prevent loss of time, discerning this, and lot of effort by the system to discern and classify the various categories of information required. If that can be generalized and a format can be provided, it will be easier for the person who uploads and also the person who studies the claim.
So, Dr. Coming to your first part, so a standard treatment guideline addresses that when it comes that what a particular procedure, what document should be there, that are well documented there, and that is the in-house effort which ma'am was mentioning for 2 packages that we have automated for dialysis and cataract, which are working nationally right now. So system checks the presence of those documents and the correctness of those documents, and system only returns it.
Okay.
Right, even now.
Okay.
It is being done. Coming to second part of it, this is a very, standardizing the format for every disease, every procedure. NMC has attempted for many diseases, but doctors are not following. DHR has issued many formats, standard formats, but I'm sure they are not being followed.
If the formats
Across
at least
the India.
generalized.
They are there. They have been published, government documents. We are taking cue from that. And our systems are identifying those, keywords and everything in our solutions. So yes, and finally, yes, those hospitals which are using HMIS and all, they are generating EHR. This issue is not there.
In our MVJ Medical College, we are having the HMI system, but this will be helpful for the overall across the board. This will be helpful if there is standardization.
Yes.
And also one more point: if there are certain things required for it is not always information available, not available. For example, a person has claimed for ICU, it might not be applicable for ICU. Then you have to go for HDU or even reduce it to the ward level. That gradation also, because I did not see any gradation of the categorization of the severity of the disease. If that can also be incorporated, so availability of that particular class of treatment or either upgrading or downgrading it can also be included, so that the person who uploads it can be knowing at what level it's been approved, the claim. Is it as it is submitted, or if there is any difference in the approval of the claim?
शैलेश आप बताएंगे partial payment.
No, he is right, sir. The gradation is required, but actually, in these cases, the packages which were given are lump sum cost packages in which wherever the patient is admitted does not matter in the final pricing.
Sir, I'm talking about the medical line of management where there are differentiations.
In those cases, it should certainly be considered. You are right.
Yeah, if
And
that
it
is
will
done,
be done.
it will be helpful, sir.
Yes, yes.
Thank you, sir.
Thank you, Dr. Pramod. Any further questions? Yes, please.
This is Rahman from SB Hospital, Chitradurga. Could you please quickly go back to the slide which was showing that 7025 and 2025? Yeah. In this, you are considering only on the year part. apart from the year, are you consulting even on the month and the date also?
Yes, absolutely. So this
Because
was,
what will happen is, on every page you can find the year part, but when you go on to the clinical notes and the other things, the dates keep changing. And for example, if the admission date is 12th and discharge is 22nd, that may read as 27th. So, because since nowhere you have mentioned or you have spoken or told that you're concentrating even on the month and the date, because year is not much of a critical part. The month and the date is the most critical part, because the patient may get admitted on the end of the month and get discharged on the next month, or like basically this 2, 5, those dates.
right. Yep. So thanks, Raman, for asking this question. And see, the point that we have mentioned over here, which is year validation, is just for illustration. We validate the date part, month part, and as well as year part in usual processing. And actually, you brought a really important point, and this is exactly where Copilot actually comes into play. For example, let's say assume there are 25 STG rules that we want to validate for processing or approving a claim. Now, just imagine we have actually validated 24 rules out of 25. One rule got failed just because of this kind of, let's say, mismatch in date or month in one of the pages, because it was handwritten, and OCR or all these AI technology, no matter how advanced they are, they can still make mistakes, right? So they were not able to read the information properly, and one of the rule which was supposed to validate the date across all the pages failed. Now, what one of my team member was actually suggesting is, that was actually one of the mid-processing failure, right? So out of 25 rules, one rule failed. Now, usually what we have seen is, in most of the cases wherever we are trying to achieve automation, we dump this case on a person and they have to validate the 25 rules again manually. But what we are suggesting with the human in the loop process is, and that is exactly what we are following inside our processing team as well, that we show a message to a processor that only one rule you need to validate. You need not look at the 24 rules because we have validated it through AI already. The only rule that has failed is date validation. On page number 7, apparently the date is not properly readable or is missing. You just go to page number 7, validate the date. If it is correct, you approve the claim. That's it. So it significantly reduces the processing time from, let's say, roughly 15 minutes to 1 minute. So that is the kind of automation, or let's say optimization, we can achieve through human in the loop. I hope I answered your question. Yeah. Any further question?
Yeah, I have one.
Yeah.
So let's say we have to add one new package. What would be the TAT and process you will have? And what would be the automation? How much manual effort would you require?
Yeah. So
before going to production ready.
Sure. So right now we are actually dealing with 4 different packages as part of this hackathon problem statement. But let's say if you want to add 5 more, let's say, packages or a different kind of treatment wherein you want to, let's say, give us 5 different STGs and the documents. Now it depends on the complexity, and let's say if the document categories are similar in nature, then it should not take much time, because we can maybe just quickly feed the new STGs into the RAG model. It will start understanding the expectations for those 5 new procedures that we are actually trying to implement. And if the documents are relatively simpler, I mean the categories of document and the information required is more or less simpler, then hardly it is going to probably take, I would say, let's say, in production I'm talking about, maybe roughly in a matter of 1 to 2 weeks, we should be able to configure one package with end-to-end testing.
What manual effort you would require precisely?
Sorry. Yeah, of course, we have to do a lot of testing, but before that, we need to first understand the document categories that are required for the new packages that we are, let's say, inducting in the system. And if we are, if our model is able to understand those documents categories, or we want to, let's say, redesign our prompt to understand more categories, so that is going to be one of the effort. Second effort is to maybe fine-tune the RAG model a little more for the new packages that we are actually introducing into the system. And once we have actually done these 2 parts, most of the subsequent steps would probably fall in place automatically, as long as we have configured the rules properly. And again, one of the point that I think Vijay was mentioning is, let's say right now, since we are actually looking at the document-based STGs, right, which are PDF formats, if we can probably move into a little more standard JSON kind of a format, which is more computer interpretable, it is going to be much more easier and faster for us to, let's say, include hundreds of STGs or different procedures or packages relatively faster.
It's just that you can create a JSON format out of it.
Right.
So
See,
it is a ePDF.
Yeah, absolutely. So the problem right now is in the PDF, it is written in English, right? I'm just taking an example. Let's say, going back to the same example, if the policy date, let's say if the claim date is between X and Y, it is written in plain English. Now, the idea is when we read the PDF, we read that statement, we feed it into the AI model with a prompt, and we ask the prompt to understand and give us the, let's say, start date and end date, the range, right? Now, while doing this, most often it will probably do the right thing, but just imagine there is a bit of hallucination that is happening in that model. It might give you incorrect information because of which your entire processing probably will fall apart. But if you have JSON format wherein you have very specific fields, start date, end date, there is no option for you to go wrong there. So that is the kind of optimization and standardization we are talking about.
Okay, fine. What is the procedure for adaptive learning? Where is the feedback going into the loop?
So right now, there is no feedback that we have actually built in the system. And that is exactly where the lang fuse that actually Karthik was talking about will probably come in picture, wherein, let's say there are thousands of claims that you are processing through this pipeline. On a regular basis, an expert trained doctor would probably look at all the outcome of these executions that we are doing through thousands of claims, and they'll be able to give feedback, and those feedback will feed back into the actual AI model or prompt engineering exercise, as well as RAG. Yeah. Thanks, Hardik. Yes, please. Can we have a mic over there?
I hope you can hear me. Yeah. So my name is Dheeraj. I am deeply involved in American healthcare systems. So I have like over 10 years experience. So I can get the gist of like where India, like ABDM, is moving forward. So even though it looks like there's a lot of FHIR standard implementation that's going on, but due to the unstructured, the infrastructure itself, like, very unstructured data, how we get the prescriptions, clinical notes and all. So the OCR, it does makes the first step in the process. But my question is to ABDM team panel itself here. So I think it looks like the certification part of it, like when hospitals, they enroll into compliance and standards, FHIRs and all. So it is being addressed with OCR or some other technology with AI and all. How does it gets audited, right? Like, AI is as good as people using it. So how does it gets audited when hospitals are actually using it or not? If even with the EMRs, it looks like probably major hospitals like Apollo and all they're using, but not every hospital that is there across the country, they're not using it. So how do we regulate it and make sure that, for example, there are certain reports like CDAG, ODAX, as they call in other countries. So that gets continuously audited, like to see if it is getting implemented rightly and the care itself, it is reaching the patients or not. So are there any measures that's from? Yes, sir. Okay, sure. Sure.
Yeah. Yeah, maybe we can catch up during lunch. Yeah, yeah. Sure. Thanks a lot. Thanks, everyone.
Ladies and gentlemen, we now break for lunch. Lunch is being served on the ground floor for all the participants. Dignitaries and panelists are requested to proceed towards the right side of the auditorium for lunch. May I request everyone to kindly be seated back in the auditorium by 2:15 sharp, as we will resume with the remaining hackathon presentations thereafter. And it's going to be very interesting and engaging, so kindly be seated on time. Thank you.
So there are 2 more problem statements for which we have 6 more winners. Okay, this was only the first one. The second one is about image classification, much more interesting. And the third one is about deep fake detection. So the frauds which are committed using AI, how to catch them. So please come back after having lunch. We'll gather here again.
Good afternoon, everybody. Welcome back. Moving on to the second problem statement, radiological image-based condition detection and report correlation, which focused on radiological images and their corresponding diagnostic reports. As both the images and reports are available, the objective was to develop solutions that can analyze and compare the findings from the images with the observations recorded in the reports, identify any inconsistencies between the two, and also detect contradictions or discrepancies within the reports themselves. May I now invite the winner under problem statement 2, Mr. Harish Kumar from team Build IQ AI, to take the stage, please.
He can.
Yeah, good afternoon, everybody. First, I would like to thank NHA for organizing this such a hackathon, which allow small startup like us to participate in this competition. So, about us, we are Built IQ AI from Jharkhand, Jamshedpur, and we have a small team who work on the regulated environment, like for healthcare. Hello? 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 Yeah, thank you. So we work on the regulated environment, whether it's a healthcare, BSFI, or EdTech. So where data is very important, where we can secure our data on premises. So we work on a solution which run offline using AI. We already built SIOS AI for US-based healthcare application, where with Dr. David Montorano, we build a patent-based solution for behavior health solution. And for India AI Summit, we developed this POC where you can compare private insurance with the PMJY, and we can see that what are the benefit in PMJY healthcare benefit against the private insurance. And in AI Summit, NHA director Vikram Paragya was there in our booth, and he told us why you guys don't doing for India, why you are doing for international candidate. After that, it encourages. After that, we decided we should participate in every hackathon will happen. We missed the exchange claim one, but this one we wanted to crack it. Okay, so this is about us, and we have our own hardware solution. We don't use cloud AI. We use own hardware where we do all the regulated work. About the SIOS AI, let me give you a brief about how that EHR works. It's a multi-agentic system which work on a very regulated environment in US healthcare. One of guy was talking about the fire and HIPAA and all those stuff. So we are highly work on that environment where we have to take care about all the compliances, PHI and all those stuff. Again, the RAG insurances, we just talk about that. It's again multi-agentic POC, but we can develop this as a large-scale product. We apply for API through API Setu, haven't approved yet, but we want to build this for Indian user to use and understand how to different benefit through our insurance or PMJY. Now coming to our problem. So problem is that NHA have to process lots of claim every day, and they have to approve the claim, legitimate claim also. So the problem is that when we provide a report or radiological image,
it must correlate with the report. So that's the problem. And image cannot be changed, the image rate and all the stuff, and report can be inflated. So that's where we have to create an AI pipeline which compares both the image and then the report, and based on that, give the human adjudicator to take an informed decision. And again, it's had to be take very fast processing. Okay. So where the AI model is used, where we use the code. So you can see that image reading, we use the vision tier of Gamma. Gamma by default is a multi-model, but we use as a to report correlation, we use the Nemotron because it has a thinking capability and the reasoning model. So that's why we use that. But before going to the LLM, we process through the classical Python pipeline so that we not consume too much token. Building an AI system, one thing we have to aware that token uses. So that's where, whether we are using a foundational model, whether we are using open source model, token usage is very important, where we can save our lots of token. So we use for image OpenCV, data extraction, we use the regex, calendar math, so that date consistency can be done. Then STG alignment, we convert the STG guidelines into the YML file. Why YML? Convert into YML, and then the parsing of the narrative so that template can be created. Now, if we use if you see that we have a two process, one is the image lane, one is the report lane. So image lane, first is check the quality. Again, it's not LLM or VLLM, it's an OpenCV which classify the image, how good his image is. Whenever we talk about the radiological image, it's always a good in shape. If it's very old, if we go to the STG guideline, if it's old, OpenCV will tell that this is a very old. Then again, vision model amplifies that. CR takes extraction from the report, and then medical model that, although we are, for medical, again, we use the Nemotron Nemo only, because for his that model capability. Otherwise, I would prefer use MedGamma or other model which has a medical vocabulary much better than the Nemotron. But here we use the Nemotron, so which parse the reports and then the check for the consistency. Again, it's a correlation. Does image support the remote? And we have a multiple section that if it's a consistent, yes, it's a straight go. Confidence level is more than 90%. 90, we can say that yes, this claim is legitimate. If partial, is informed for the human reviewer to check that. Again, if unsupported, again it notify the human user to check this manually. Again, STG and timeline, right package, right mobility. So based on our STG guideline, it should check because all the radiological image has the date on it. So based on the date and the report, it could correlate with each other. So based on that, and again, whatever the output, we use the JSON output, which our model can run, read, and then the reviewer PDF. We use Python, any Python version more than over 3.12, it can work. MyPDF, OpenCV, NumPy. What happened? Reboot it. Yeah. That's okay. We use Gamma and Nemotron Nemo for this. It took us to process 40 claim 82 minutes, but it can be improved. In sandbox environment, we were given 16 GB of RAM and 4 CPU, but and we can only run only one worker. If we run a multiple Python worker, then we can improve that that process. Again, if how our algorithm worked. So if image shows the hyperinflation in lungs is present and report says hyperinflated lungs, it just check the keywords. Based on that, it can say that it's consistent, and for quick approval consideration, said if it's written in that particular gallbladder is unremarkable, but in present, again, it's a partial supported. We cannot say that it's a fake or fraud. Human reviewer can review it and then process, but again, this will be the slow process. So that's how our algorithm work, where if a report is consistent, it can go for a faster process. If report is not consistent, then it will go for the human reviewer part. And our so for what we believe that layer can do the document forging. So first we have to check that if document is forged or not. If it check in the first place, first step, we can reject immediately, and it cannot go to the layer 2 or layer 3. Layer 2 is our problem statement 1, where page classification, field instruction, all the NLP, and then the timeline validation can be done. And the third layer will be the our PS2, where evidence with the so this is if we are going to scale this complete solution, we have to go through. So this kind of this process to in this most of the other open source model, but I think if we use a better model, then we can process more claim more efficiently. Again, diagnosis, tone leak, honest. So what we not seen is not means not accessible. If image LLM or my code is not able to process that document, I think it should not be rejected right away. It should go to the human reviewer to check that. And it was an air gap solution in Sandbox where no data is going outside the NHA environment. And this, right now we run on the AWS environment. I think NHA can run on the, instead of using AWS, can we run on NIC hosted GPUs? And even this solution can run on the single hospital or kiosk using a DGX Spark, like a small AI machines, which can run offline. It can run also, because we already tested all those stuff, and we understand that we can run that offline also. So where are the different failures? So we talk about that gamma model capability, where image, it cannot be understand. So what we did, we added an open CV gate which identify and classify the image first. Then the reporting. Most of the hospital, maybe some hospital purposely write the wrong report, or report is something we cannot understand. That's where per package chronicle phrase and STG rule need to match, and based on that we can decide whether it can approve automatically or we can send for the human reviewer. Again, image quality false positive. Yes, image can be degraded, or OpenCV can be give the false positive. So, and that case, not seen or normal is coming. We again, if confident is less than 90 score, we can tell the human reviewer to check that again. Data extraction, yes, sometimes handwritten multilingual data cannot be extracted. Even in our solution, we not allowed to use Tesseract multilingual, where we can do with the Indian language all those stuff. But if null or failed, I think we can data unreadable flag again. It can be assessed manually. One of the previous question was asked how we are going to onboard new package. So how we are going to onboard new package? We convert all the STG into YML configure file. We don't need to change our code, anything. We just add a YML extension file. It will work with the algorithm. So we don't need to train or process our data through RAG or any AI model. We just need to put the proper YML file. the config file with the new guidelines or new package. How we can improve that? If we have to develop a complete fraud detection system and the claim processing system, we need a GNN graph neural network which can learn itself. How it's going to learn based on the previous data processing and all those data proper level data. Model can run itself, and then it's continuously online. It will adopt how it's going to be. And same method we use in SIOS AI also, where based on the patient previous document, it suggests the provider that what kind of treatment can be given to that particular patient. So same method we can use here also. Again, for Indian context fine tuning, yes, we have to work with the multiple Indian language where we can, but if NHA can standardize these process through the FHIR messages, because that is very important part in healthcare. If we standardize the messaging process instead of handwritten document or a PDF. So that should be an policymaker should look forward it, and I think it's compulsory for the hospital to use FHIR standard of the in their EHR. So these kind of things, I think if we upgrade, then I think it will be a very good system, and I think Indian healthcare need those kind of processing, because if we see the complete processes, how the healthcare works, like in opening remarks, sir was saying that yes, in US you have to wait. Even a European country, you have to wait for a treatment for weeks and months, even over small ache and stomach. But in India, providers are very fast. But if we give them a right tool, I think we can solve one of the problem. And what I believe in India, that we are still not using EHR or digital document for healthcare. This is where I think if we start using it, I think healthcare is the first industry which can be fully capable for AI processing. So I think this is where we can really work on it. So how the all system will work? So this is a data table that we thought that should work. So like if integrity is there, the document is clean, then it comes to the PS1 rule. If it's passed, consistent, auto approve. That's how we can. If again is a first step is a tempered document, we don't need to directly label that is a document fraud. Again, if clean, PS2 can be skipped, and honest non-compliance, because query hospital about the messaging is whether it's a wrong package or whether the report is not there. Again, third step, if we have a clean first and second step, third is not supported, then high priority fraud signal, real document and rules is followed, but report, image and report is not matching. It means there is some fraud. So those kind of things we can implement, and then our GNN can learn. And also the pattern, it can identify which hospital follows this kind of pattern, and it can detect that. So it always alert that if request coming from this particular agency or hospital, we can manually verify all the document, so that those documents not pass through the automatic process. Thank you. Any question?
How you are using actually GNN for real-time working, basically, particularly, offline it is, static analysis is okay. But while processing the claim, how you are handling it?
So how GNN works. GNN works is a pipeline where we have an approved data set. So we label the data that these are the approved and these are the rejected data. So GNN is an algorithm to automatically understand this kind of system is approved. There is a detection if 3 layers, 2 pass, 1 is fail. So GNN is using an algorithm which using the graph neural edges of the graph, it can learn, okay, it's a correct document or not, and it keeps feeding us. So it using my own data. So data set that we are processing, where we are saying that it's claimed approved, not approved, how much time is manually approved, based on those GNN automatically learning that process. So that's where so that pipeline we need to create. So first we have to see the NHS system where they are approving all those and disapproving the claims, and that data need to feed it to our GNN algorithm, and GNN will start working. So we have to write the algorithm by looking that data and then start approving or disapproving the claims. So I think I saw just a second.
Any one case today?
Yeah. So this is again from our test data. So we given the one test data. It's a claim number PMJMH SGR, where image shows the hyperinflation of lungs is present. So what happened? Vision model checked that although we got the JPEG or PDF, we prefer DICOM, I think, direct radiology image format. It will be much easier for LLM to learn. So, and report says hyperinflated lungs, like doctor like to say in 2 words, or report is say that. So that's one. Both are consistent. Based on that, it's a reviewer action, quick approval for. So that's one example. Another example of fraud signal is again it's the same. We use the data set provided by NHA. Image shows the gallbladder is unremarkable. Yes, it's in ultrasound is not showing the stone or anything, but reporting multiple gallstone and required an immediate operation or kind of thing. That's kind of claim come to the NHA mostly. Both are the partially supported, is not accurate. So that required a escalation closure so that human reviewer can review that both image, and so you don't need to go through all the files. You just have to check which flag for the review. So that saves lots of time for a reviewer.
We are interested to know about your approach for these false documents, like tampered documents. Yeah.
It's a problem statement 3, where it's a different group. Actually, we participated in all 3, but we won this. So this presentation is regarding PS2. But yes, as a whole system, fraud detection done via first stage, where we didn't selected in this hackathon. But yeah, so we use again OpenCV and Python library to identify. It's no LLM involved in that. So it's a pure classical programming there to detect the.
So it will be coming in the next set that will be presented?
No. We are. So problem statement 3 is different.
Excuse me, I'm not sure the question what I'm asking is concerned to about this, or this software support us whether the amount being claimed for one particular package is sufficient enough or will be added up, or how we have to work on this.
So this is a problem statement second, in which he demonstrated how we can actually correlate the radiological image or a scan with respect to the report. So that was the only problem statement which they have worked on. To answer your question, so that is different. Yes. So
how is your image? You are concluding that hyperinflation in lungs is present from the image data.
So it's a vision model. It reads the image. So LLM reads the image and it tells that. So although we use Gamma, which is not very good in vision, It's an older model, but newer model is doing much better than in vision. But yes, vision model can read nowadays, even if you
Okay,
upload.
so the model already has that training and it gives that
Yes,
it is
yes.
present.
So they trained on the multiple medical data and all those stuff.
Okay. Can I have one? I'll give you. So for GNN, how you are handling heterogeneous data complexities? That is my question.
That's we haven't because
So-
data
so-
I need data I need to understand first. Then I will create the pipeline based on the data because the data that said we got is a very limited. So we need to understand that what kind of data we are getting. But algorithm can be created based on understanding the data.
How are you handling a case where in a report or a lab report has been made which was not necessary? Essentially, one is where fake lab report or something that, like that has been mentioned, but one case might be where there is a waste abuse, not exactly hard fraud. Some unnecessary investigations had been made. How would you counter that?
I think that's when NHA is doing that.
So for the problem statement too, the problem statement was if you are given let's say X-ray. First of all, whether the X-ray is of the same patient for which the claim is submitted. There is no forgery or there is no name change. There is nothing has changed. Then you have a report which is attached with any diagnostic, doctor signs it. So another thing was to check a consistency in that report. And the third part of the second problem statement was to check the consistency between the diagnostic report and the report attached with the diagnostic report. The consistency, what X-ray is saying and what the report attached with the X-ray is saying. So they have that limited option. But you are asking the deep fake, that's the third problem statement. And and another thing that you asked is, let's say somebody has, it was not required. Let's say diagnostic was not required, but that hospital has done a diagnostic just to inflate the bill. So that is catered in the first problem statement where it was like all the documents required as per STG is there. If there is any extra document, that auto-adjudication engine will mark that this is an extra document. So then the reviewer or adjudication can happen accordingly.
Thank you.
Thank you so much, Mr. Harish. Thank you so much, Mr. Harish. Next, may I please invite the runner-up under problem statement 2, Team Kantaka Sodhna, for the presentation.
Hi all. Good afternoon, team of NHA. Good afternoon, everyone. I'm Hambika, and we are Team Kantaka Sodhana. We are very glad to be here to present our solution for the PS2 radiology claim adjudication. So, first of all, when we look at the sample data that is given to us, the data contains many radiology images and the clinical notes. First thing that we need to do is we need to match these both, whether these both are exactly matching with the same person or not. And the next thing that we need to do is whether they're following the SDG guidelines or not. If these three are done, this is the main problem statement. And then the reviewer need to correct the validate whether it is right or wrong. So why we need to produce AI solution for this? When we are doing manually, reviewer need to undergo for every image, every clinical notes. It will be difficult for the reviewer to do every time. So, and again, it is variable integration. Based upon the documents the speed and the consistency may vary. So, and as they're humans, we'll do mistakes, right? So we need we need a solution for this problem statement, so that we have produced with a scalable and lightweight, robust solution. So we have divided the approach in 4 stages. The first stage here is preparing the radiological images. We are matching it with the clinical notes, and then we are comparing it with the STG guidelines, whether they are following it or not. Now we have used the Gamma 312B here for extracting the images, and we have used the Ministrel's 8B for extracting the text. Now we are matching these both. Then we are producing a JSON output for each and every claim that is given to us. So next, my teammate Bharat will continue the presentation.
Hello everyone, my name is Bharat. I'm a third year BTech CSE student. So let's continue with the presentation. So let me talk about the workflow of our solution. So at the first stage, we ingest the files into the system, which is necessary so that we get the perfect PDFs and also clinical documents that are matching to each other. Then we assess the quality on a grade scale basis, if the image is blur or it has a certain type of exposure which makes it unreadable. And we interpret the image using our models. Then we analyze the report. First we interpret, then we analyze for better understanding of the radiological image. Then we correlate this both to find if they are correlated or not. Then we check the STG stage. We check these so that we can tell if the radiological image and the clinical documents follow the STGs or not. And then we generate the outputs such as JSON and summaries for reviewers. So the next one is core architecture. The architecture separates the evidence extraction so that it is easier for us to map out each and every stage of our solution. So at the first stage, it is case intake and routing, where we process the claim folder, file typing, and package detection. And then we use PUMY PDF. It is a Python framework for the PDF pages we get. And we expose the text that we get from that to the downward model, which is the Gamma 3. In the Gamma 3, it is a vision reasoning model that we have used for it. It applies the modularity specific prompts so that we can get exactly those things, and it searches for exactly those things in the images. The next is the text reasoning layer. The text reasoning layer, we have used Ministrel 8B, which has a 8 billion parameter. We check the reports and we correlate them both, and we also do the STG logic in this one. And the output orchestration is done by Ministrel as well, where we validate the data that we have collected from both the models and also the nested JSON export. So this is the prompt design we have used for this problem statement. So the prompt is in a library. So we have a header prompt, meaning that every of the prompt follows the header prompt and then goes to each of the packages. So for coronary angiography, we tell the model to focus mainly on LMCA, LAD, and LCX. Whereas for chest X-ray for COPD, it needs to check for lung fields and hyperinflation. Whereas for ultrasound abdomen, we need to check for liver echo texture and also the size, also gallbladder stones. For the KVU by PCNL, we focus on the pelvical system of the hydrophenosis and the stone location which is present in it. So scaling and the control of this is, we have certain limitations as well. So the advantages right now is that it has package specific prompts which makes the model works easier, so that it is traceable intermediary outputs. And also we use deterministic JSON mapping which can be inputted into any other dashboard or something else. Also we have certain limitations. The model still requires a human review. It does not replace the doctor. It basically acts as an adjudication tool for the doctor. The next one in the limitations is poor images, such as we have got many poor images. So if the image is poor, the model extraction of the image will be very low, so that it won't find correctly clinical documents. The current specialization that we have developed the solution for only covers the 4 package families that we were given as data, not the entire claims one. For scalability, each case is independent, so batch processing can be parallelized. And adding a new package is simply and fairly easy, as we just need a prompt remap adding to the prompt library, and also we need a schema map for it. The same orchestration can be fed into different reviewer dashboards and logs and queried workflows. This is the AI usage that we have done. We used Gemma 3 for the vision and Ministral for text model. For Gemma, the tasks of Gemma is only for image interpretation so that it does not hallucinate much, whereas Ministral is just for text so that it doesn't hallucinate much. This split is really needed in our case because these model tends to hallucinate a lot, meaning that depending upon one giant prompt, sending it to one model is not a viable option here. It reduces hallucination risk as each model does a narrower job and the outputs can be cross-verified as well. From here, Dr. Manohar will carry on. Thank you.
Good afternoon, everybody. My name is Dr. Manohar. My inputs into this particular tool which we are speaking about are especially into package prompts. As our friends has told that the tool needs a human intervention, which is a clinician. So here is where I take my part in contributing to this particular tool. So we have basically worked on 4 different packages which were given to us. One is PTCA, the other one is chest X-ray for COPD and exacerbation. And the other packages were cholecystectomy, which is without exploration of the CBD, and the other one is PCNL. So each and every clinical package which we are speaking here has got a substantiating evidence which proves whether the case is genuine or no. So here, depending upon the clinical data which was provided to us, so we have taken out the substantiating evidences for the individual clinical package, which is for the PTCA, it might be stenosis of the coronary arteries, and for the chest X-ray, it might be the shadowing of the X-ray or the consolidations which were seen in the X-ray. And the same way, coming to the ultrasonography images of the cholecystectomy, which we have seen, here it depends on the stone being present in the gallbladder. And in the same way, we can see for the PCNL also, where we can see the stones in the X-ray images of the PCNL, which are like KUB, kidney urinary bladder, and the IVP, intravenous pyelogram. So this is where a clinician shows their inputs, especially into these 4 particular packages. Thank you.
Good afternoon all. As Dr. Manohar was mentioning, this problem statement can't be dealt by AI alone. So we had to take the help of human labeling as well. But the data, what we choose is a partial data, means the golden data set we have taken out of it. And we had built a tool separately for doing a human labeling as well. So as you are seeing here, we had a package-specific labeling, which Dr. Manohar has helped us. And also prompt designing also we have done through this tool itself. Finally, the same prompt was given back to the AI model what we have developed actually. That has made it much better actually. So the human labeling has really played a major role in solving this problem for us. And finally, the rollout part, Bharat would take it.
For like the scaling of this solution, the first one, we start with CPD and PPD. We use the reviewer side supporter for the current packages. We measure and track the mismatch detection and review time and consistency structured outputs. To extend, we can add new packages to this as we only need to update the prompt libraries and the schema maps. We can integrate and connect with any other dashboards and audit logs as well. In this, what must scale is that KSS parallel processing we can do it better, prompt library expansion and also schema-based export. What must take control is human control. It should always be in human control. We cannot depend on AI alone for treatments. So a human sign-off at the adjudication is really needed as the solution clearly defines it. Thank you.
In this angiogram case, but report is negative, AI, how it will consider fraud or genuine?
So our thing is not about fraud or genuine, it's about correlation. So we just check the radiological image and the clinical documents and see if they match or not.
It can be, if it is claimed, then it will be passed?
If they both match, then it will get passed.
Manual thing. The correlation with the clinical assessment and the reports is being done through the software, or?
Yeah, it is done through the AI model that we have chosen.
AI
At
model.
last, the doctor can review it and check if there are any irregularities.
Okay.
Hey, do you see a use case where they'll be recycling the positive images? Obviously, they have to edit a little bit of the patient data.
Yeah.
But do you see kind of a creating of signature of previously detected images and trying to match if that is already been used? Do you see some kind of a use case like that?
We have seen it, but not with respect to this problem statement, though, sir. But provided if that was the thing, it's a duplication what we can do actually. As part of another forgery or some other thing, we can take that up this case actually. So you were saying already if a process document comes, do you really deal with it again, right? So that's what. So already if a process document is there, we will keep a separate stamp for it and keep it aside, and we need not process it again. Because already that has been processed. So we have a mechanism to deal that as well. But as part of this problem, it was not the scope for us. Yeah.
What is the mechanism to deal with false negatives here, which you are not able to capture?
So the human labeling, as I said just now. So
that will capture the false positive. What about false negative?
False negatives as well. For instance, whatever the tool we have developed actually, even the false negatives, of course, we could not handle it right away. But more training on that front, that would help us to solve this part as well.
And so, let's say you have given an X-ray. So, how you were able to capture it with respect to the report, whether the X-ray is pre, post, and in report, how you were capturing the nitty-gritties of it? Because in a single report, you might have a single report in which both parameters would be given, or you would have a different report for that. So how you have correlated these two segments in your problem statement?
So let's take an example of angiogram or a heart stunt. We know that before taking off the X-ray on the heart stunt, we know that there won't be any stunt, but we can see a small of a blockage if it is visible. So in the post one, we can see a metallic one that is a stunt that is present in there. So it is easy to correlate between them and then the clinical summary.
Yeah, so this is between the pre and post X-ray you said. What about its finding in the report, in the printed report?
If it doesn't have it.
Yes.
If the report doesn't have it, it tries to correlate what is there. If it's not there, then it will give it for the review for the doctor for betterment of that.
This you have handled in the prompt or prompt.
Yeah.
Okay. Can you tell me like one example what prompt you have given for this particular?
I'll just show you. So let's take ultrasound for example. This is the package specific prompt that we've used for this. It analyzes ultrasound abdomen and describes the status of these specific things such as liver, gallbladder, spleen and kidneys as well.
No, I think, yeah, thank you. It's a very nice presentation and hopefully it will be helpful. One query where you said the stunt, those are the external things which can be visible as the pre and the post. But when there is a admission for some kind of a shadows, for example, there is a pneumothorax or some other fusions are there, and that will be cleared after subsequent treatment. So for that, how would you able to make it that it is, how many days of treatment it has happened, correlation of the same person's shadow, right? There will be pneumothorax of one person, clear X-ray of the other person or the same person. So those kind of matching, probably you will have to find out some criteria.
Yeah.
Maybe I can suggest you can have the bones or ribs or whatever body part you are taking care of that. So that matching should be appropriately done with the pre and post of the same person and after duration of interval. So does that addresses here completely or maybe? Shadows जो जिसकी वजह से sometimes because of there is a false X-rays or the true X-rays and all those things probably will need to because
Yes, ma'am. I understand. Why? Because as you were saying, that is completely subjective to a particular patient. And as we know that depending upon the clinical scenario of the patient also, this falls into a technical hypothetical situation. Why? Because as we all know that you're speaking about shadows. Some shadows, they are permanent. Why? Because if it is a COPD and we know that it is a chronic obstructive pulmonary disease, then the shadows might be in the X-ray for a more period of time. So depending upon the subjective things and fine-tuning it and multiple readings, we'll be giving the tool different kinds of prompts depending upon the fine-tuning and studies of multiple levels of X-rays, depending upon the treatment protocol which is being extended.
Yeah, this will be varying from the chest X-ray or the MRIs and the brain shadows and all that. Any part of the body, it will apply to that.
Yes.
Yeah. Thank you, everybody.
Thank you.
Thank you so much, Team Kantaka Sodhna. May I now invite the second runner-up under problem statement 2, Mr. Arnold Sachit, a research associate, to take the stage, please.
Good afternoon, everyone. My name is Arnold Sachit, and I'm a research associate and teaching fellow at Vidyashilp University. Before I begin my presentation, I would like to thank Dr. Smita Rao for her continued guidance, and a special thanks to NHA CDPG for giving this opportunity. So the agenda I would like to keep my entire presentation pretty much simple. Look at the problem statement and the end-to-end flow, the results, the challenges, what we faced and how did we approach them, and our solutions, advantages, limitations, and the future work. Okay, already there are two teams who have already spoken about the the problem statement and the objective. The whole and soul, the main objective were to understand what the image is, whether it's X-ray, etc., other images, and correlate whether the report and the image actually, they match, and whether they're consistent, and also look at the STG guidelines as well. I mean, also looking at the timeline if they were uploaded at a particular time. Straight away getting into the end-to-end flow. So we have beneficiaries who will be uploading the claim documents. So the claim documents can be both the images and the correlated reports together. And so it will be into the PMJ portal. And our block number 1 looks at how do we actually handle these documents which are uploaded. I will get into each of these blocks in detail. Especially in block number 1, I'm primarily focusing on handling the image quality and uncertainty. And block number 2 is the main AI engine. Once we have pre-processed the images and documents, then the Gemma model actually looks at it and tries to do the image feature extraction, the correlation, and looking at whether it is consistently, etc. And then finally comes the output from this block number 2 gets into block number 3, where we try to convert these findings from the AI engine into a human readable format, so that the the PPD and CPD, the reviewers can actually look at it in terms of a PDF. And yeah, that's the final review. So I will now get into block number 1 particularly. So the two types in the data which was provided to us, we saw two types of data. That is, one is a PDF and then images separately. So for PDF, what we did was we took each of these pages, converted them in terms of images. So it will be, let's say PDF has 20 pages, then we are going to have 20 images. And then we also try to merge the only images part as well, and calculate how many total number of images do we have. And based on that, we were doing some sort of image enhancements for the AI model to help it to make a better decision. So if there were less than 12 images, then we did 2x the zoom quality so that AI could actually look at a much better image and with a 90% quality. And subsequently for 13 to 50, we had 1.5x zoom, and 31 to 54, we had 1x, 70% of the quality. And then we converted these enhancements into base 64, which further gamma, we were using these data for gamma, and that entirely concludes the block number 1. Now, once we are done with block number 1, we take the pre-processed images into the block number 2. And in block number 2, what happens is we have a list of 64 images coming from the block number 1, that is enhanced images. And then we particularly see for a package that is MG0298, for I'm taking one example here, do we have the STG rules already extracted for the gamma? If it is not there, then what we do is we take a gamma separately and then we provide the STGs from the NHA and provide some basic prompt to it. And it will actually create the set of rules which are provided by STG. And this is a one-time process. And specifically, this was done so that scalability was not a major issue moving ahead. Let's say tomorrow, now we have built it for 4 packages. Tomorrow, when we want to scale it up for 100 packages, so there's no lot of a human intervention required to sit and write the rules. So once the rules are ready for a particular package, we take the images from the image enhancement, push it into Gamma 3 billion parameter, and I've also used 12 billion parameter model. And we get a proper JSON output which NHA expected us to do. And this is entirely block number 2, where we are core, the whole heart and brain of the, the entire process is in block number 2. And then the JSON which is generated goes into block number 3, where we try to generate a PDF for the final review. Now, looking at the JSON, this is how the NHA actually expected us to give us a structured format. So we had image classification, whether it was chest X-ray, and post-procedure image description, what exactly was happening, and the validity of the reports. And finally, section number 3, as you see, does the report actually align with the STG rules which has been provided? And then that completes block number 2. And block number 2, whole and soul, looks at the image feature description, claim package alignment, and all of those things were taken care in block number 2. Moving on to the final block, that is the validation and summary generation for the reviewer. So we took the JSON itself and we took the Nemotron 30 billion parameter model, because through the studies we got to know that it was very good at reasoning. So JSON was put in, and even the STG guidelines were also fed to the Nemotron AI model. And we got a PDF like this, which kind of in detail spoke what is actually wrong in the report, what is matching, what is not matching. All of that was a PDF, around 4, 5, 6 pages PDF for the final reviewer to have a look at it. And so at the end, what the reviewer will see is, okay, the claim condition is correct, STG guide, it matches with the guidelines, but it's not matching with the episode timeline. So, there were some questions in the morning. We don't want to make things much complex. Just give us some, indicators on the screen which says that what is wrong and what is correct. So that we can go back and always have a look at it. And then these are some of the results which we got. Of course, along the hackathon, I did track some of the results. So you see the overall F1 score, which Gamma 4 billion parameter actually did much well. But then I had to little bit look at this table very carefully. Of course, the gamma 4 billion parameter, this model was brilliant at, giving out the, the correlation and the results. But if you look at one particular package, that is SG039C, we saw that gamma 12 billion parameter model was actually doing much better for that particular package compared to Mistral and gamma 4B. So what we did was, for our final approach was that for these three packages, we used gamma 4B, and for this particular one, we used gamma 12B parameter, and ended up, this was the overall F1 score, which we got during the hackathon. And then our solution, the pros is, in terms of scalability, you have STG rules which are extracted on the go, and of course, 2-model architecture along with Nemotron, which is very good at reasoning, and structured JSON output. So this is where we try our best to reduce the hallucinations as well, where we are forcing the model to give us this particular output. And coming to the scope, of course, we are limited to some specific models provided by NHA, but we could have always expanded to Gemini, Provision, Gamma, MedGamma model, etc. And we did not fine-tune anything. We just took the model and we had to work on this hackathon. And we thought we could still do a lot more image processing. Right now, we just did basic, zooming in and just maintaining the quality. So that brings me to the future work. So probably we could explore much better models. Domain fine-tuning could be done, which will actually help with getting a better accuracy. And image pre-processing pipeline, there are a lot of OpenCV packages which can be used to enhance the images. And model ensemble technique and specialized medical CV computer vision models, which could actually, jump up the accuracy of for this problem statement number 2. That's all. Thank you so much.
Yeah, thank you, dear. And quite a good approach in the 3 blocks level and quite validated. First question, where is this university?
This is in Bangalore, ma'am, near Airport Road. So.
Okay,
Yes,
in Karnataka.
That's correct.
Okay, correct. You mentioned, some kind of that for less number of images, the
image
zoom
enhancement.
level is going to be 2x,
Right.
and for middle of the images, 1x, 2x, and 3x, and all that. So whatever information you are getting it from the hospital or from the records and all that, I guess everything needs to be zoomed at the same level, because we don't want to miss it out. Even if it's a 64 images, why not that all to be zoomed out at the same level? Because minimum information may also be there in every kind of a image, whether it is a PDF document or is a radiological image or whatever image it is there. So I think that was one thing. I don't know why you put it up that, because of the maybe the volume of the work you wanted to condense it to that. So I don't think that it should be reduced, that zooming parameter should be reduced 1x, 2x, and 3x. It should be all similar, so that the clarity on all the documents is there, number 1. And number 2 was that when you are having these 3 different categories, actually I'm not an IT person, I'm just a doctor. So I'm just trying to find it out. Sometimes there is an incomplete information. So how are you going to address those information which may not be matching with what radiological image you are going to have it out? So any parameters or anything for AI tool which can match it up both the documents properly. Maybe there may be multiple such documents which may be required. So that was 2 comments. Lastly, I think it needs extensive, thorough, AI memory model to be trained at length to give it a quite accuracy level to reach up to the proper information.
Yes. So answering the first question, the reason why I have put those hardcore numbers is that the model which I provided was, let's say, at 2x zoomed in. It was not taking anything about 12 images. It was telling that the size is exceeding. So that's why for the models which I provided, I had to constrain it like that. But I completely agree that it's not fair to downsize for the higher number of images. And one more thing is that I tried my best to amalgamate images and the reports in one shot when it was seeing it. I did not go, one image at a time or something like that. So the AI model was seeing everything at one shot. But yes, with better models, we could actually solve that issue. And second question is that, again, the thing is that I'm trying to push whatever the claims are coming in together, and AI is trying its best to correlate with the images and the written report and see what is actually going wrong. And even in the, I really thank the NHA even for the masterclass which was provided. They said that I'm just taking, even I'm from a tech background, I'm just taking some examples. Some examples which are provided was that the stunt was actually put in the left, but a report is telling that it is in the right. So these sort of irregularities has to be, checked for, and AI has to reply. So. Any other questions? Thank you.
Thank you very much, Mr. Arnold Sachit. Now moving on to the problem statement third, which was document forgery and deepfake detection, which I believe attracted a lot of attention. This problem statement focused on assessing the authenticity of claim documents and identifying possible tampering or forgery. The objective was to develop solutions capable of detecting manipulated or forged documents, including instances such as content editing, watermark removal, copy-paste manipulation, erasing, partial image alteration, etc. May I now invite the winners under problem statement 3, Mr. Praveen Sridhar and Ms. Snehal Joshi from Team SOPA Claims, to take the stage, please.
Hello, honorable dignitaries on the dais. I am Snehal Joshi, co-founder of SOPA Claims. Before this, I used to work with Aditya Birla and Deloitte on the operations side. Currently, we are helping in the claims processing and providing FHIR-enabled solutions to the providers. So as part of this problem statement, we were given 10 different categories, out of which 9 categories had some sort of forgery or tampering as a part of the outcome. The 10th was the completely clean document. Now, why was this particular problem statement very difficult to understand? Because a lot of times what happens, that any sort of checks or whatever methods we use, they overlap with the outcome. So necessarily, for example, like an overwriting text or an edited text might sometimes give a same category output. So that is where this challenge, one of the challenges we encountered. Another one was that, the documents we received were small and isolated locations were found where the tampering was done. So it was not necessarily entire sentences or, large paragraphs. So it is tiny, tiny point on an entire document. So, so we tried to approach this on a proposal first basis. We tried to isolate the locations where the problems were flagged instead of going entire page wise. Instead of having one very big rule engine where we had 10 different rules, we tried to isolate and create many weak detectors. So as a cumulative, that is how we flagged the tampering. And lastly, some of the domain insights helped. Taking the historical understanding into consideration, there were few fields which are more susceptible to tampering. So we tried to also monitor that before, tried to monitor that especially. So moving on to how we actually did this, I would like to ask my co-founder.
Good evening, everyone. I'm Praveen Sridhar, co-founder of SOPA Claims, and previously I used to work as a data scientist at BCG. So we had multiple stages. The first stage that the documents were passed through is the layout context stage. Basically what we are trying to understand here is that within the page, what is the structure of the page, where all are the individual components, where is the name written, where is the dates written, and what are the bounding boxes for that region, so that we understand the overall structure of the documents. Following that, we have a stage 2, which is a detector bank. So what we do is there are countless computer vision techniques which can be used to detect different types of tampering. So we run our image plus the layout context. So both the whole image and the individual bounding boxes of the different context that was from the previous stage through all of these different techniques. And create a full set of candidate boxes along with the score of confidence, whether this detector has given a high confidence or low confidence score. So one example of such a detector is the ELA. What happens is that when there is some content that is copy pasted or like tampered with, so in this case the line items 4,200 and 5,255, so those are probably copy pasted from somewhere or tampered with. What ELA does is that we take a replica of the image, we compress it to another level of compression, like 90% JPG compression, and then we compare the two images and take a subtraction of the image, which will result in this right hand side document. And there we can see that the portions where some tampering evidence is there, that gets slightly highlighted, and it becomes a candidate for further processing. So like that, different computer vision methods give different types of output. This is one such example. Stage 3 is the most important stage where, whenever a document has come, now through these two stages, there will be countless number of bounding boxes which have information about the text and what the content is, and what type of tampering could it have been. What we do is that we combine all these together using multiple techniques, and then there might be detectors which give very similar bounding boxes. So those very close by boxes can be combined together to give a single box instead of multiple different boxes. So we do all these sorts of post-processing to get the final regions of interest. The tools and techniques that we used, like mostly we've used all open source libraries, PyMu PDF for PDF rendering and like getting images out of the PDF documents, OpenCV, OCR models. For different computer vision analysis, we use SciPy, OpenCV, NumPy, PyPDF2, etc. Some of the scalability considerations. So essentially, this task involves a lot of trial and error because there can be countless ways of how documents can be tampered with, and it can be a very minor change. Like the overall document might be very like an authentic one, and there might be one small place where a small edit has been done. So to enable this trial and error, we do per page caching so that all the computer vision runs. We don't need to rerun the entire thing, and we can quickly experiment with different types of merges. We have all stateless detectors. We have ablation switches. So sometimes what happens is that there are n number of detectors, but not all are useful for each type of tampering to be detected. So we have switches which can be turned on and off depending on the trial and error that we do, which helps for further processing. The key challenges that we faced was that there were a lot of overlapping categories. So what we did is that we grouped these different categories together. So an example would be, so you can see here the categories C2, C3, C9. So overwriting existing text, added content, or partial AI edit. All of these can have similar boxes and similar evidences. So what we do is that we group all these 10 into different family of types of tampering, And then within each type, we, according to the confidence scores, we select the maximum, like the particular row which has the maximum confidence score. And then another challenge was that C9, the partial AI edit, when we pass it through detectors, it can give n number of boxes and like reduce our score. So what we did is that we know that most of the such tampering, partial AI edits happen like by just giving the AI to say that generate a small image which has some other name or some other date. And then that is copy pasted over the original document. So during the OCR stage itself, we have a list of common fields, and for the C9 one, we specifically run all the computer vision detectors only on the smaller bounding boxes that are for that are nearby the name or nearby the date regions. That is mostly about it. Thank you.
How much of human in loop is required? Because most of it is tech is detecting this problem, right?
Right.
So if you detect a problem that it is tampered,
right.
How much of changes do you see a human can actually make a difference in by looking at it?
So it depends on the category of tampering. So some of these categories actually, so for example, watermark removal and all, it will be very difficult for a human to totally understand, because watermark will be like very small and meant to be not seen. But in some cases where there is copy paste within document, a human in the loop becomes very important, because there can be like the detectors, computer vision detectors can give some bounding boxes, and then there can be a human verifier who can verify by zooming out the image and seeing that there is a clear separation in the maybe some color contrast is there, some texture difference is there between what was copy pasted and the original document. So that sort of improvements can be done.
So you are giving the reasoning also what they should. Are you giving what the human should do to?
Yes.
Okay.
Yeah. Ideally, we are. I mean, in the human in the loop solution, we're telling that this region could be tampered with. This is how like you should zoom and look at the color difference, look at the texture difference, etc.
Thank you.
How are you tackling fully AI generated images? Because sometimes what I've seen that even the best of the models are not able to catch whether this is AI generated or not.
Yeah, that's a particularly difficult category. So what generally in the industry also what we do is that like we have large data set of actual genuine documents, right? So genuine documents and genuine images actually have some sort of a signature, so kind of like a texture, which proves that like it was taken by a camera. It is like there will be some lighting differences, there will be some light source, like there's a light source here, and if I take an image, the light will be spread across and coming from here. So that image, the image will have some properties which will show that there's a single light source or multiple light sources. In AI generated images, some ways of detecting is that it is extremely consistent everywhere. So every part of the document is like completely free of any irregularities in lighting, irregularities in texture. That sort of analysis can be done. So we are using multiple such detection, but again, it is a very hard problem, and it's not a foolproof 100% accurate solution right now.
One more question. So if we have multiple documents, and in one of the document we see a partial AI edit, that was the class where you faced a lot of issues.
Right.
But in rest of the documents it's fine. Like everything else is fine, but it's just one document in which you see something is off.
Right.
So do you compare across documents, or you just compare that document standalone?
Right now we are comparing documents standalone. We're not checking for other like other places or like similar document copied or not.
You mentioned that ML is optional here. So
Right.
what are the different techniques which are used to combine the weak detector? And do you give the same weightage to all the weak detector, or like some of the weak detectors have the more importance as compared to others?
Yeah, there is. The weightage actually comes from a lot of trial and error. So we pass like a few images. We see what all regions have been coming out. We take a look at like we manually check whether it makes sense or not, because a lot of these techniques are like very statistical and very prone to small irregularities in original document itself. So original document itself will give like, let's say 10 or 20 regions, but out of that only 2 or 3 might be the actual ones. So we get the 10, 20 scores, we do some manual checking and then tune the threshold so that different detectors can be spiked based on that thresholds. We can select which all are used. To answer your first question, we are using a rule-based system to combine all the detectors. ML is optional right now because in this problem statement we did not have labeled data. So if we have labeled data, we can like train a classifier and like use the features from that to do the combination. But currently, since that was not there, we're using mostly rule-based combination.
Okay, so I have actually gone through your code.
Okay.
I have few queries over it. So particularly for space between the content, right?
Right. Irregular spacing.
Irregular spacing. You are looking for the extra spacing and not for the less spacing.
Yeah,
Is it
mostly.
it is a deliberate attempt or?
Not a deliberate attempt. I think somewhere when we were tuning, there were 10 categories, so we were tuning for each of them one by one. So I think for irregular spacing, not much. It was already giving decent results, but we did not focus too much on that. So maybe that can be an added thing which will improve our score for sure.
Yeah, so you had false positive because of that.
Yeah,
that
I had
is one.
false positives.
Okay, so on the copy paste, you have used ORB.
Right.
Am I right?
Yeah.
For how many pixels?
The specifics will have to go through.
1200.
Yeah.
Why? How you have chosen 1200 pixels?
Again, a lot of trial error. It's not a hard and fast thing.
Have you explored any other approach other than ORB?
For this one, no.
Okay. So have you were you able to get results around C6 category?
C6, not really. Like we only checked whether there is a like particular white patch added for removing watermark, that sort of thing. But
And
nothing otherwise.
for partial AI edit?
For partial AI edit, we're looking at whether there's a change in texture.
So have you got any result of that for that?
I think we have.
There was no partial edit.
Okay.
Worries. Thank you. Okay.
Just one small, when he said that irregular spacing,
yeah.
What about the alignment? Because once there is again a copy paste and erasing of the document,
right.
And then of course when there is a tampering, spacing will be affected.
Right.
Right. So that is what about the alignment also? Probably that also you can.
Yeah, definitely. That's a
consider
very good
it,
idea. Yes.
because
for sure.
alignment will also change if you are going to have some kind of a tampering. Number one. Number two was that I was thinking about handwriting you have not taken into account. It's all PDF documents and all that, because lot of tampering may happen for that also. Lastly, I have also seen in some of our government sometime documents that, and especially when it's a claim, right? It's a claim for that procedure, and we have also claim for our bills, hotel and stay and everything. So I think it can apply to that also. But what happens is that I've seen the documents, same being produced, just changing the dates and all that, uh, we don't have the mechanism to pick it out. That how do we? So is there any system that when you go back and check the records, maybe some quite proportions of those, they can be 10% or 5% or whatever proportion we may decide. If there are certain doubtful situations that can go back and find it out, just to give a higher quality of, that whatever has been done is a proper way.
Right. I think what can be done is that like first level information we can get from the system, and then once we get the first level information that okay, some portion of the page seems to be tampered with so and so confidence, then maybe we can have a system that can go back and check the other records also and see whether things are matching or not. Where exactly did the change happen?
It gives you more accuracy and more confidence that whatever the feeders are being going to give is accurate in detecting.
Definitely, that makes sense.
Yeah, adding on to that, what ma'am told, when you give the confidence level, will it be telling the percentage of deviation from what is supposed to be and what is going to be observed? For example, 70% fake detected or 80% like that. This is one question. And second, will it verify with across the, claims documents of different patients, or it will limit to the claims document of one patient?
So right now it is independent. So it looks at the single document or set of documents. Other than that, the confidence score depends on the detectors that we're using. But essentially, roughly, we can say that it is trying to give a bounding box and say that what is the probability that this bounding box would be a tampered bounding box.
Does it affect the geotag photos also if it contains tampering of especially geotag photos?
Right.
Because on the patient, is a patient on the bedside as an OPD or inpatient? Because usually the MRC will come in the name of just patient photo only on specific days in latitude and other things. But they are supposed to give as per the rules and regulations on the patient bedside or when they are undergoing the treatment.
Right.
And is there any mechanism to differentiate those things?
I think in this problem statement, mostly we had written documents.
Only written, not with respect to geotag photo.
Yeah.
Actually, nowadays, geotag photos is very important.
Definitely.
Without geotag, we cannot pass the bills.
Yeah.
Sir, we have solution for geotag as well in-house. Yeah. NHA has, sir. We identify forgery in the geo. Yes.
For different dates,
Yes,
how we
sir.
have to differentiate? That's, is there any?
So that comes under reference forgery, sir. And to answer ma'am's question as well. So if the document is same and some part of the document is forged and resubmitted, be it patient name, date, etc., anything, and we have record of that, image in our database, so we can detect that.
With the
Yes, sir.
How can you put a clause for the quality of the paper which is being sent as a PDF document? Because original paper, then they do forgery and then a photocopy and something like that. So is there
Right.
any mechanism we can capture that as well as a part of your,
I think if we have some standardized, standardized system where we know that which paper is being used, and we have samples for that, then we can do some sort of comparison, I think. But I'm not sure if standardized papers or this sort of things used.
No, I mean, the government system, the papers are normally standard, but you come to know it's a photocopy
Right.
document forged.
Yeah,
so
some texture analysis and all will pick up on it, yeah.
computerized produce statements. They suppose the signatures are there. How exactly we have to recover with PDF only? Patient's consent.
Yeah.
Yeah, that signature especially. And
Right.
apart from that, one more to continue Madam's statement again regarding the bills when it comes to computerized automated bills.
Right.
Without signature, sometimes it comes, or else if signature comes, whether how we have to whether really CPD that is sent it in PDF form, suppose.
Yeah, I mean, if it is a like physical document and the patient has signed, and then
It will
upload
come
it,
as a
it
PDF
was
statement on the soft
correct.
copy. How
Correct.
is it there? How we have to different? Is there any possibility of differentiating fake or not?
So if digitally some signature has been added, there might be some difference in the color gradation of the paper that was the scanned image versus the added one.
Scan photos will come straight away as an
Right.
attachment.
Right, right.
That is there any possibility of difference? Because we don't know when we are processing for the MRC,
Right.
we have to just see, believe, and we have to document it.
Yeah,
That's
it is definitely a challenging problem.
because
for
it
sure.
is a
Sir, to answer your question, whenever a third, external elements are being added on the paper, let's say you are talking about some signature or a stamp, which is being added over the and rescanned and submitted to the department for the adjudication. So that area particularly gets, the area of that paper gets enhanced pixel. So you can analyze that and that area can be highlighted.
so for MRC claims we do get any confirmed fraudulent cases, confirmed reject cases, and again it comes for re-signing also, e-signing after PM from the PFMS itself. Is there any possibility of differentiating with this kind of applications
Right,
of this
right.
kind of software technology?
Right. So
Because it, especially fraudulent cases and CPD rejected cases, all these things will come for our e-signing. Again, for e-signing, 2025 or 24 signatures will come for us.
correct, sir. Correct, sir. So category 1, copy paste within document, it is there, and category 2, it is for that only. We can have rules over it, which we can run, so it can be identified.
Awesome, thank you.
Thank you, Team SOPA Claims. Next, may I invite the runner-up under problem statement 3, Mr. Nikhileshwara Rao and Ishwar Machara from Team for Gensic for the presentation, please.
C-type है.
C-type भी है सर पीछे. एक बार ट्राई कीजिए.
डुप्लीकेट करना पड़ेगा.
हाँ चलो विंडोज पे डुप्लीकेट नहीं है. हाँ बस.
So, good afternoon everyone. We are team Forgensic and comprises of Nikhil Rao, Shivalal and I. I am Ishwar Machara, a third year CS undergrad from Arogya Nujvid, Andhra Pradesh. And we are working on document forgery and defect detection. So this is from problem statement 3. And coming to our problem statement, to give you a glance, as you know that Ayushman Bharat, which is one of the India's largest public health insurance scheme, where here hospitals basically submit claim documents, discharge summaries, bills in the form of PDFs or images. So these are processed at national scale. So you can understand this is a big scale problem where in between tampering of documents can happen. So our duty is to find a solution that detects these tampering. So as this is a big scale, manual reviews are not feasible and sometimes they seem impossible. So basically these are the prominent tampering categories. These are copy paste, overwritings, and up to partial edits. So before designing the solution, without this. Instead of choosing a random complex AI model, which is mostly black box, why don't we choose a simple explainable AI model that doesn't need a complex neural networks or complex AI model. So this is mainly, so we chosen a approach, simple classical computer vision algorithms along with statistical modeling. With these techniques, why don't we build a model? So with that approach, then the scalability is good because we don't have any computational constraints since we are not using any highly computative models. And then as the model is simple and we are using mostly classical computer vision algorithms and mathematical approaches, it is mostly explainable and it is easily deployable. And of course, there is no computational constraint. The latency is also very less. So to have a glance about our system architecture, so initially the input, it is either in PDF or in image format. So there are two pre-processing phases, which is rendering pages. So the PDF is rendered into pages, and then this is the quality gate. So to detect the tampering, so the document has to cross the quality requirements. The quality requirements include blurriness, contrast, and text density. So once it is passed this, then it will be fed into the 9 gates. So these are 9 individual detectors which run in sequence. So the ultimate approach is initially the document will be having some prior distribution. So after tampering, so at some regions, the tamper regions, the distribution will be shifted. So each detector, I mean from C1 to C9, each detector views the document in different perspective. So later, once the tampering regions is detected, bounding boxes and all are localized, and then the final files are exported. So already these are the 9 tampering prominent classes. So explaining how each... do you have HDMI? Sorry. Yes. HDMI port? Yeah, we have. Yes. So as I explained earlier, each detector views the document in different mathematical perspective. So I will be explaining all the 9 approaches. So coming to the first one, copy paste. So here we'll be using the ORB detectors, where these checks about the copy paste is nothing but some regions are extremely similar. So these detectors' main work is to find those regions, and it is labeled as C1, and then C2 overwrite, where here when some text is overwritten, it leaves some inconsistencies in edge density and stroke width and also ink darkness. So this detector mainly looks into these inconsistencies. And then C3, added content. So this is nothing but adding fake stamps or seals onto the original document. So basically, these distributions and the original document distribution is mostly different. I mean, this has a distinct ink color and other characteristics. So this can be done by converting the image into HSV color space. So there we are operating on the document or image. And fourth one, eraser. So basically, when we erase some content in the original document, so will be at that reason, the distribution is abnormally smooth. So this detector will be viewing that, and it is labeled if the particular region is abnormally smooth as a C4. And then C5, document merge. So 2 different documents having 2 different distributions, and when they are merged, definitely they will be having different noise floors. So different paper structures, so different characteristics in the distributions. So they are detected as document merge. And finally, next, water removal. So when watermark is removal from the original document, so it actually leaves some invisible ghost traces. And these are actually exposed by fast Fourier transform and Clahe enhancements. And the last 3, irregular spacing. So basically when the text is extracted using the OCR model like tesseract, so then there is some abnormal distances between the tokens, extracted tokens, since this actually interprets the irregular spacing. And then AI-generated document. So basically, AI-generated document has flatter distribution and uniform text textures. And coming to the last one, partial AI edits. So it is simple. Initially, the document is having one prior distribution. So this partial AI edit is completely foreign to that. So we can easily find these two different distinct distributions. And the rest is explained by my teammate Nikhil Rao. Over to you.
Hello everyone. Hello everyone. So my name is Nikhil Rao and I'm an third year undergrad at Adjudicating Newsweed. So coming to the main detection engine, like in the mathematical perspectives, rather than using the mean based Z-score distribution, we use the median based. Why? Because mean actually does an overall average upon all the values that are in the document, but we want a separate distribution from the real and also the forgery based content. So here we use the median based approach for Z-score, that is known as MAD based robust Z-score. That is median absolute deviation that we use here in the formula of Z-score. And what is this constant of 0.6745? That's a general constant that we have used by trial and error to make the values like for taking into consideration and to taking up to the values of how Z-score normally gives us. So where it actually fires. So here the main use of MAD is used at C2 class, C7 classes, C9 classes at main prayer. And coming to the challenge faced and how we addressed. So first one, the major point is the diverse scan quality. So here we use like robust diagnostics and also the MAD based features, because MAD will have individual page based like the separations. So it will handle all the diverse scans that the pipeline will get. And the no GPU constraint. So our main motive is of the design solution is coming up with our initial idea of scalability and CPU based. So this is a completely classical CV solution for this problem. And auditor trust requirement. So we have all the math back detectors and also per page bounding boxes in YAML format. So we can for surely show all the proofs for the detected class. And coming to the multi-mode tampering, we have modular detectors and also the post-processing for and like the merge routines that we have in the pipeline. And coming to the dependency variability, like we have written a very robust codes where it can handle all the try and except blocks. And coming to the resultant impact, in the internal validation of this hackathon, we have got the score of 0.5315, and in the external validation, based upon the metrics and also the performance of the solution, we have placed the top 2. And we are like good here to say that our solution actually achieves a inference time of 1 to 3 seconds in average. And one more thing, the major thing, that is we do not use any model files. So this will help in deploying our solution in a very basic manner, and it is like very easy to use in the customer side. So here I am going to show you like a live demo of my project, where the users can actually upload an image right now here. Let me just restart. So where users can upload an image right now, and this will start the automatical processing of the document. So this actually is completely deployed in the online, and it's the database in the backend is stored in the Cloudinary database. So apart from the detection, we can also know about like what all classes that this document has got, and also it can also process JPEGs and also the PDFs also. And coming to the other features of the solutions that we have developed, so here is a review platform. So even though the model has generated with the mathematical proof, but we keep a human in loop format of like reviewing all the boxes. So suppose if I want to annotate this box or like mark a review for this box, I can simply click on this box, and this box class and all the dimensions will be projected here, and I can write any comment here and mark as review. Or else I can make this box highlight and mark as false positive also. And also we can get an overall history of all the users that we get here in the platform. So this platform uses Google sign-in for user-based analysis system. We can click any image and like see how the detection has been performed, and we can also move to the review for another phase of review. And coming to the insights section, we have per class basis insight for this account, and also the number of uploads, reviewed, false positives, flags, or the average inference time that we have got for this. So we can also count upon the reviewed and false positives count. And then we have an admin portal where the admin can actually manage and see how many classes are being detected through the class distribution, and the total number of users and their uploads and their performance upon the platform. So this is our beyond the hackathon thing that we have done so far. And one more thing that we can add up here is that if we open this site in your mobile phone, you can get an mobile camera option where you can directly upload the photo through your camera, and this process will take it automatically. And thank you for listening to our presentation.
Very good presentation. Really, it is exhausting. But my question is that one patient is treated in a hospital, secondary care hospital, but claimed in a super specialty hospital of their own branch. How will rectify in this?
Sir, basically this solution is working in between the communication line between hospital and the scheme.
Yeah.
So I think we don't know the details happening between the patient and the hospital.
As is rightly said, geotag photos, this may be a one, I think, wherein it may give some solution.
Okay, sir, we'll consider it and work upon it.
Okay, thank you.
Yes.
So you have shown a lot of mathematical equations. So how do you come up with that equation? Like, is it part of your background research, or have you found that maybe those equation-related calculation in your data, from your data, you derived it from the data? That's one thing. The other thing, like you in the initial slide, you discussed about deep learning. Later, like you moved for the some kind of feature engineering or some kind of analysis, which you explained along with that equation. So generally, deep learning don't expect any feature engineering. How we incorporated that, like that engineering part along with the deep learning? How they are connected?
Sir, initially to come up with the solution, so we thought let's not go with complex AI models. We have to go something which is explainable. So for that, so whatever it is, the data is completely from the distributions. So it's all about probability distribution. So we thought, why don't we go with this? So and then, I mean, referring some textbooks like Understanding ML by Ben David and other textbooks, and taking AI support like ChatGPT. So we have refined our ideas and then tried that. So it had worked. And then coming to the next thing, so we have not used any DL related thing. Feature engineering is mainly related to, I mean, rendering the pages and then quality gate. This is all about thresholding operations only. So I think we have not done any feature engineering that is closely related to deep learning or machine learning. So the one thing we have done is extracting the text using Tesseract OCR, and then, I mean, looking at the token distances. That's the only thing we have done. So, okay, sir, now I totally got your question. So, we initially thought this will help. So, it's all like trial and error. So, first we came up with this experiment. So, it has worked. So, on coming to, I mean, checking the error, that is, I think, it's our future work. So we have to have the human in loop system and also find where the model or detector actually getting wrong. So and we have to update those things. So
Okay, thank you guys.
thank you.
Thank you, team, for GenSig. Finally, for the last presentation of the Hackathon Showcase, may I invite the second runner-up under problem statement 3, Team Shushruta Health AI, to take the stage, please. Yeah, okay.
Good afternoon, everyone. This is Team Sushruta Health AI. I, Meghna, standing before you to tell the problem statement 3 that we tackled. Uh, Here, to put it simply, our goal is to build a solution that can automatically find and highlight the exact spots in a document where someone can find it where tampered has been. In this, we aren't just looking for the whole document, we are just focusing on the tiny spots where specific changes some might try to hide. Now, why this is so hard? In the real world, documents aren't really very perfect. We have to deal with very messy data, things like blurry photos and mobile cameras photos. Here, even the forgeries can be mistaken. Images may be rotated and in a wrong way. On top of that, we had constraints like no GPU training and LLM with no internet. It has to be completely specifically contained. Coming to this slide, we have found that most images in the scan can be blurry and with the low contrast, faked ink and poor lighting. In the compression, in one of the 5 images have low quality issues and aggressive cropping may lead to cut the edges of the images. This taught us a simple and fast approach cannot be worked for this. So in these approaches, we first tried with the computer vision approach, where edge gradients and pixel statics and fixed cutoffs were very difficult to find. Like even we used cutoff mathematical thresholds here to find them, but accuracy was very low for us in this process. And we went to the next process called quadrant hash comparison. In this, we are comparing the 2 images where this is not very specific to get this in, like to get the perfect solution in this part. So we adopted the solution of deep learning where we used transfer learning and CPU friendly. We trained the LLM and, not LLM, I'm sorry. We trained the YOLO and CNN with the subtype classifiers, models and levels instead of matching one threshold. So I would like to pass it on to the next teammate, Balamurli.
Yeah, thank you, Meghna. So, as we can see in the slide, how we label humans and humans verify. Before using any deep learning model, we need good quality labels. for training. So that means humans need to annotate and verify the type of forgery with upon visual inspection. To address this, we built an in-house annotation tool that can specifically help a human to label different categories that were given to us. So coming to this approach, the methodology we have chosen is a pure human-in-the-loop data science approach. Like first we understood the problem, then we explored the data for quality, image quality to understand its characteristics. Then here comes the label part where we used our custom-built tool to label a small set of sample from the given data. And we trained our deep learning model on this labeled data that we consider as gold data. Then we evaluate the model, and finally we deploy it. So this is the basic architecture. As you can see, like the first we get the images in we get the claim documents which are in both PDF, JPG, and different types of images formats available. Then there are 3 architectures that run in sequence. So one is the page classifier, which is built on an image classification model, a CNN model, which is a lightweight CNN model, and it's an open source model available. MobileNet V3 small is the name, and it classifies the given image into 9 forgery classes. And then a region detector will further check for where the forgery has happened. So, and in the subtype classifier, we are given for some categories like C3 and where like categories like C3, added content, and partial edits, AI edits, and some categories where we had to identify a specific type of the bounding box element. So for that we are using a subtype classifier. All of these will run in sequence on an image, given an image, and these outputs would be saved in the format mentioned to us, like in the JSON, and the bounding box coordinates will be saved in the YAML. So why this approach? Like we can individually dissect the model, and like if suppose the region detector is not working correctly, we would try and label more data and try to put it as an input data for training, and that could increase the accuracy of the model. And yeah, now I'll hand it over to Sumant from our team to discuss the metrics and key challenges and how they can be overcome.
Thank you, Murli. Let me walk you through this slide. Starting with three numbers at the top, our page classifier, the model that looks at the document page and decide if it's forged or genuine. It gets 85.7% of the time right on the validation data after the training. The third number, 0.578 MAP, which means mean average precision, is for our region detector. This is the model that draws boxes around the exact areas where the forgery happened. For a small model trained on limited data, this is a reasonable starting point. MAP is basically how accurately the model draws boxes around the right areas. The higher the accurate score, the better it looks, better it identifies to. The subtype classifier does something more specific. Once we know a page is forged, this model identifies what kind of forgery it is. It is a pasted signature, or it is a pasted copied stamp, or edited text. Now, how did we all build this? We used Google Colab for our training the model, PyTorch first for our training framework, OpenCV we handled images processing, Rapid OCR helped us to extract the text from the documents, and PyMuPDF handled PDF rendering. The model architecture are MobileNet model for classification and YOLO Nano model for object detection. Both chosen because they are lightweight. The entire system is just 10 MB, runs on a CPU, needs no internet and no GPU. Coming to this slide is a honest take on what went well and what limitations we have. Starting with what works, we split the problem into 3 separate models, one per task. Instead of building one giant model and that tries to identify everything, each model owns one decision. Is this page forged, or where exactly happened, and what type is happening? So this made it faster to build, easier to debug, and if one model needs improvement, you fix just that one without touching remaining other. Transfer learning was a big win for us. Instead of training from scratch, we used models that already understands image classification and fine-tuned them on our data. This works much better than handwritten rules, especially on noisy hospital scans and where image quality varies a lot. The ONNX plus CPU setup means this runs within hackathon constraints and also works in the real deployment. ONNX is a portable format that lets us run our models on most standard hardwares without needing PyTorch or any heavy frameworks. And our human verification step, where every label was reviewed by a second person, gave us a clean training data that helped model converge faster. Now the limitations, and we want to be upfront about this. First, human review is still needed when new document type comes in. The model hasn't seen every hospital document formats. And second, if a new manipulation techniques or a new ways of forging documents is invented or used, the model needs a freshly labeled data to identify those patterns. Third, the lightweight version of YOLO object detection model is built for speed, not maximum precision. Really subtle forgeries like tiny pixel level edits across multiple eras may need a bigger, heavier models. Every choice was driven by the data we had, the constraints we were given, and putting quality where it matters the most. That's why we believe the approach is practical and scalable. Thank you. Thank you for giving this excellent opportunity. It's been a great learning experience for the entire team.
Hey, this is Krishna. For labeling, what is the data size you have? For annotation, you have annotated?
We are given a data set of 829 images, but it was difficult to label identify each and every kind of forgery that category. So we've labeled around 20 to 30 images per class of 10 classes of images.
Okay.
Categories, yeah.
So what is the accuracy with that?
Just let me go back to the slide. Okay. For the individual identification of forgery class, we got around 85.7 accuracy. And the subtype classifier, those are only for specific categories within the forgery types. So that was around 96.5%.
So when you say subtype, is it that C1 to C9? That's what.
Yeah, within the C1 to C9, there are some categories where we have to identify if some stamp has been placed or some signature has been copied. We had to identify like what is the type there. Yeah.
Okay, thanks.
Why there is so much difference between region detector accuracy and other component accuracy? Means what kind of error you have noticed in the region classifier, maybe like which is not occurring in the subtype classifier and page classifier?
So the page classifier works for all the 10 categories that have been given. Subtype classifier works on only some categories like C3, C5 and C9. So those categories deal with identification of what is there inside that box. Like so why we observe this much high accuracy and less accuracy for the page classifier is there could be a chance that our model got overfit. But if given enough training examples, we can reduce it. So, yeah.
Sorry.
any reason for going for the transfer learning? What other models you could have tried with? Have you tried CV and other models or not?
Yes, we tried CV computer vision libraries as well. But the thing is, for whatever we have seen, for computer vision, it is easier for us to use it for assessing the image quality, not like classifying the images into the forgery classes. So in a transfer learning process, the model already understands the image features, so it is easier to build on top of it to help it learn, to train it learn, understand all the image forgery categories. So yeah.
So this is a follow-up question. This region detector, the 0.578,
Yes.
it looks low,
Yes.
whereas the subtype classifier 96.5% is very high.
Yes.
So are these really in sync? That is the question. With 0.578,
Yes.
will it give 96.5% accuracy?
So the region detector is a separate module. It just identifies the boxes, but the subtype classifier is not specific to the boxes. It identifies what's inside the box. It can be a stamp or a signature for some category of forgeries that we've seen.
Okay.
Thank you, everyone.
A warm round of applause for all our hackathon winners. Thank you for the innovation, effort, and thoughtful solutions that you have brought forward through this initiative. Ladies and gentlemen, that brings us to the end of a rich and meaningful day one. On behalf of National Health Authority, India AI Mission, and the Indian Institute of Science, Bangalore, thank you for your presence today. We look forward to seeing you bright and early tomorrow morning. Have a restful evening. And please carry your delegate batches for tomorrow as well. Thank you.